Good evening, Doctor. I, Shuman, on behalf of Shield Healthcare, welcoming you all in today's mixed bag webinar session organized by the Rachi Obstetrics and Gynecological Society. And it's my honor to introduce Dr. Archana Pathak, Madam, mostly of today's program. Madam is the Medical Director, NDLM Hospital and Research Center, Rachi, and Associate Consultant, Medica Super Specialty Hospital, Rachi. So, with this short introduction, I request Madam to take over the session for further proceedings. Thank you very much.
Thank you so much. Good evening and namaskar. I'm Dr. Archana Pathak on behalf of Ranchi Obs and Gynecological Society. It's my proud privilege to welcome the assembled distinguished faculty as well as the audience for this webinar. This enlightening and informational event will improve upon your healthcare practices. So it's time for all of us to come together and invoke the blessings of Ma Saraswati. I request all eminent personalities to please come together to light the lamp of knowledge, happiness, and good health. Can we have the video, please?
Kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam dhanasampadah Shatru buddhi vinashaya Deepajyotir namostute Deepajyotir namostute Shubham kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam.
Thank you. The theme for this year at Foxy is Foxy for All Always. Dhira, stop violence against women. Foxy for All Always will strive for the girl to become Sahasi with Swasth, Samriddhi, Swasth to be Surakshit with Sakti to reach her full potential as a woman. Now, I would like to present video message by our respected Foxy President, Dr. Shantha Kumari Madam.
Dear friends, Foxians and women of my country, I am Dr. Shantha Kumari, President of the Federation of Obstetrics and Gynecological Societies of India. As a little girl, I told myself that I have to become something to make a difference. I always believed that if I desired something wholeheartedly, there is a positive force which makes it happen. And here I am, friends, standing in front of you as the 60th President of Foxy, the 38,000 strong committed body of OB-GYNs taking care of women's health in our country. As a young girl, I realized that women play a key role in this world, just like Mother Nature or Stree Shakti as we revere it. It is a guiding force behind all forms of God's creation. And it's only a woman who can actually create a new life.
Hi, I'm Kareena Kapoor Khan and I'm so happy to be here with you, if only on video. Pregnancy is a beautiful experience and I have loved having my babies. I congratulate Dr. Shantha Kumari as taking over the 60th president of this eminent organization.
Stree Shakti is the embodiment of 5 elements: the sky, the air, the water, the earth and the fire. Any imbalance in any of these 5 elements creates chaos and calamities. Similarly, when a woman's health is neglected, it disrupts the universal equilibrium. The intimate link between environment and human well-being is very well known. With increasing awareness of the need for clean water, pollution-free air and pesticide-free food.
Hi, I'm PV Sindhu. Well, it's such a beautiful feeling for me to be an empowered girl, to be a girl in a nurtured and a safe environment.
Protecting health by preserving nature and its ecosystem is easier than curing any disease. So we have taken up the concept of minimizing the female morbidity and mortality and fetal effects by mitigating the adverse impact of environment. My theme this year goes beyond Foxy's commitment towards women's healthcare. Foxy for all, always.
Foxy for All is another inspiring campaign. What you do in this organization impacts the lives of all of us women in India.
And Dheera, to stop violence against women. Foxy for all, always will strive to make the girl a Sahasi with Swachhata, Samruddhi and Swasthya. To be Surakshit with Shakti to reach her full potential as a woman.
Dr. Shanta Kumari with the theme Foxy for All Always and Dheera Stop Violence Against Women will empower many girls. I firmly believe that only a safe girl, Surakshit Kanya, can grow into a healthy woman, Swasth Mahila.
Violence against women. I think it's a silent pandemic, and I'm so happy to be a part of this campaign.
If any woman has a problem, where does she go to? Not to the police or court or the lawyers. She goes to her friendly OB-GYN, who is her first point of contact for help. So I have started Dheera, an initiative close to my heart, to sensitize our OB-GYNs, the police, the public, and to partner with men to say no to violence against women.
I completely support her vision and mission as President Foxy and also especially support her campaign, Dheera Stop Violence Against Women.
A healthy environment is the core of a woman's health. A healthy woman makes a family happy and a strong nation. I, as the president of Foxy, declare my commitment towards women's health and safety.
Thank you, madam, for a wonderful, inspirational and encouraging message. Now let's proceed. I request our president, Dr. Suman Sinha ma'am, who is well-respected, dynamic personality who is doing her best. She is a senior consultant OBGYN at AH IVF and Infertility Center, Morabadi, Ranchi, and ex-chief of medical services and HOD at CCL Hospital, Ranchi, East Zone Coordinator, Medical Director in Pregnancy Committee, Foxy in 2019 to 22, President Ranchi Society 2021 to 2023, Convener Public Awareness Committee, Foxy 2011 to 2013, Secretary Ranchi Society in 2005 to 7, Vice President of SOVSI Bihar and Jharkhand chapter in 2021, and ma'am was also the organizing secretary East Zone Yuva Foxy 2005 and now the organizing chairperson for the East Zone Yuva Foxy in 2022 and has many awards to her credit like Dhuru Shah Appreciation Award. Ma'am is also contesting for Clinical Research Committee Foxy. My best wishes to you, madam. Now I request Dr. Suman Sinha ma'am to welcome our chief guest, our first woman Secretary General Foxy, Dr. Madhuri Patel madam.
Thank you, dear Archana, for the very generous introduction. A very warm and cherished evening to all the esteemed faculties and delegates. With due regards to our Foxy President, Dr. Shanta Kumari Madam, Secretary General Foxy, Dr. Madhuri Patel Madam, Vice President East Zone, Dr. Basab Mukherjee, and Vice President South Zone, Dr. Faisal Louis, I take the august opportunity to welcome all the dignitaries to this mixed bag webinar organized jointly by Ranchi Society and Kerala Society. At the very outset, I take the honor to welcome our very respected, very honorable Secretary General Foxy, Dr. Madhuri Patel Madam, whose presence has added grace to this occasion. Next, I welcome our very eminent stalwarts of Foxy, our guest of honor, Dr. Aswath Kumar, past Vice President Foxy, Dr. Rajendra Singh Pardesi, former Vice President Foxy, and Dr. Maya Verma Madam, past President of Ranchi OB-GYN Society and my teacher as well. I welcome our very knowledgeable and a very dedicated, eloquent speakers, Dr. Subhas Malya, Dr. Ajay Mane, and Dr. Sujit Kwandkar. I welcome all our very experienced, highly accomplished chairpersons, Dr. Saijas, Dr. Pramila Menon, Dr. Jyoti Ramesh, Dr. Prasanna Kumari, Dr. Rekha Jha, and Dr. Kiran Trivedi. I welcome our esteemed moderators of the panel, Dr. Sangeeta Menon. I welcome all the dynamic and vibrant panelists, Dr. Geeta AP, Dr. Simi Kumari, Dr. Meenu Priya, Dr. Deepthi PS, Dr. Deepa Madhavan, Dr. Reena Godsara, and Dr. Archana Pathak. I welcome Dr. Kiran Trivedi, Secretary Ranchi Ops and Gynae Society, and Dr. Archana Pathak, our MOC, for their constant support. I welcome our academic partner from Shield Connect. And now I take the privilege and honor to introduce our chief guest, who actually needs no introduction. But I would like to say a few things about her. Madam is embodiment of knowledge and excellence. In spite of that, she is very humble and very polite. She has the honor of being the first female Secretary General in the history of FOGSI. She is our inspiration and role model. Yes. The CV flashed here is very generous and small in comparison to what actually she is. She has served as Secretary General FOGSI. She is Secretary General FOGSI currently, and she has served as Joint Secretary FOGSI 2009. She has been former committee member FIGO for preterm birth. She has been associate editor of Journal of Obstetric and Gynecology of India, or favorite the Jogi. She has been honorary clinical associate at Nauroji Wadia Hospital, Parel, Mumbai. She is honorary consultant at Police Hospital, Mumbai. She is visiting consultant at St. Elizabeth and Messina Hospitals, Mumbai. She has been former professor and HOD OB-GYN at PGIMSR MGH Hospital, Mumbai, and she was former associate professor at GMC, Mumbai, India. She has been awarded with so many awards and accolades. She has been awarded with MOGS, Mrs. Saleja, and Mr. Narayan Pandit Award for the year 2019 to 2020, and has delivered guest lectures at national and international levels with many keynote addresses and oration. To her credit, there are more than 50 publications in national and international journals, and she has chaptered many chapters in various books. She has also been associate editor of FOGSI award-winning book, The Gynecological Cancer, in 2007, which you all have read. Thank you, madam, for being with us here. A big welcome to you. And now I would take your blessings for this webinar. And we are eager to hear from you, your pearls of wisdom.
Thank you, Dr. Suman, for your kind and warm words. Respected our guest of honor, Dr. Rajendra Singh Pardesi, Dr. Ashwath Kumar, who are past Vice President of FOGSI, and we are friends since many, many years, and we had opportunity to work together in FOGSI. Then we have our guest of honor, Professor Maya Verma, who is also past President of Ranchi OBGY Society, Convener Dr. Suman Sinha, President Ranchi OBGY Society, Dr. Kiran Trivedi, Secretary Ranchi OBGY Society, our Master of Ceremony, Dr. Archana Pathak, then our speakers and Chairperson, Dr. Subhash Malia, Dr. Prasanna Kumari, Dr. Rekha Jha. I must say, Dr. Rekha Jha, since the webinar has started and since she has taken over as a president, we had so many webinars, and I'm really happy to know that you all are so active. Sometimes we never come to know in the head office, and because of these webinars, we are, I really know now each one of you by name and which society you are from and who is that. And Rekha is also doing a fantastic work. Suman, you also are doing fantastic work. And it is really good for FOGSI because we all are fulfilling FOGSI mission. Then we have today Dr. Saijas, again the young, our chairperson like Subhash Malia, Dr. Pramila Menon, Dr. Sujit Konkar, Dr. Jyoti Ramesh, Dr. Sangeeta Menon, Dr. Geeta AP, Dr. Simi Kurian, Dr. Minu Priya, Dr. Rani Lakshmi, Dr. Deepa Madhavan, Dr. Dipti PS, Dr. Reena Godaskar, and all my dear friends. Very good evening to all of you. At the outset, I would like to thank Ranchi OBGY Society for honoring me as chief guest for today's webinar. As a Secretary General of FOGSI, Suman has mentioned so many things about you, myself, and I'm really thankful to you, but I would like to take this opportunity as a Secretary General to say a few things about FOGSI, that FOGSI is the most vibrant, prestigious, and one of the largest OBGY professional organization in the world, with 263 member bodies and 38,000 plus members who are committed to women's health. The FOGSI mission is primarily reduction in maternal mortality rate, but also we look after overall health of the women. Of course, we have 263 societies, and as I mentioned, that all the societies are very, very active and vibrant, and we are happy to know. Just now I mentioned about the Ranchi Society, Bhagalpur Society. So there are many societies who are very active, not only doing academics, but also doing CSR activities. So this is really our FOGSI mission, that we are committed to women's health. Then I would also like to mention that, FOGSI committee chairs, as you can see, Subhash, Raijas and all, they are also very, very academically oriented, and they are really doing good justice to our FOGSI. Then I would like to mention that FOGSI has two academic wings. One is our ICOG and the journal. ICOG, we have a training programs, certification courses, and we have fellowship and membership. Then Jogi has bi-monthly issue where that is total 6 issues in a year. And during COVID pandemic, we could not print our journal. Since last 2 issues, we have started printing, and all of us have received the printed copies, and we distribute all these printed copies to all 38,000 plus members free of cost. If anybody has not received, please contact me or the FOGSI office. Why I'm saying this? Because almost 1,000 journals have come back because there was no proper address, or there was nobody in the house or something sort of there. So I request as a Secretary General to all of system to update your data. One is what is portal as member.fogsy.org, where you can update yourself on that portal. And in case you find difficulty, you can ask FOGSI to update your data. So this is the second tier system we have. So why I'm saying that I'm very keen that you should update, because now the nominations are over. We have sent the consent form, we'll receive the consent form, and the election is going to start from 21st March. And we are going to block the portal on 15 March. So if you have not updated your data, you will not be in a position to, do the e-voting. And I must also tell you that this time the voters are 30th April 2021. The subscription or the membership we have received in FOGSI up to 30th April 2021. Because of the COVID, the year got changed. Dr. Shanta Kumari and Alpesh had a 1.5 years, so the year has got changed, and the voter list will remain as 30th April 2021. That is January 21 to 30th April 2021. So in case you have paid your subscription now and new members in voter list are not found, so don't get worried. It will be happening in the next year. So this one thing I would like to say, and so please update before 15 March. We have been sending SMS. You must have received the SMS. Every week we are sending now. Twice a week we'll be sending up to 15 March. So our voters, they know that they have to do updation for e-voting. Now another thing, that this is about as far as our elections are concerned. But I would also like to say that today's topics are really fantastic. Infertility, endoscopy. So we are aware that by default, we all are infertility specialists. We are all sonologists, not only obstetrician and gynecologists, but by default, we have become expert in everything, right? So therefore, we should know. Now, if Subhash says that, I want to put a infertility patient endoscope, laparoscope, hysteroscope. So we have to know as a general gynecologist when we should go. In my time, when 15 years back, with the patient used to come to infertility, we used to put a laparoscope first, hysteroscope first. But now everything has changed. that you give ovulation induction for 3 months. Then when you want to do operate, that time you put on endoscope. So it depends upon, the gynecologist to gynecologist. So we should know in and out. As far as the sonography is concerned, we are very, very into PCP and DT. So I would like to say the first trimester, early pregnancy, you should know what is normal, abnormal. But I will stress upon that you should be very, very, well versed with the PCP and DTX, so you don't fall in problem. So as a default, we are all sonology, infertility specialists and everything. Then another thing is medical legal problem, which topic is very important. I think Ajay is expert in that. And I have heard him so many times. And we have to be well versed with the medical legal problem. Very surprising, the patient whom you never expect that they will do complaint against you, they are doing. Because nowadays I have found that whenever you are talking to them, the normal thing, when they call up, you talk to them, they do recording of that part also. So, I'm really surprised that a very, very, people, patient who doesn't know anything, still that can do recording of your conversation. So, you have to be very, very, particular, enter everything, what you have seen, time, date. I'm telling you, time, date is very, very important. So these medical legal issues, everybody is going to face, and therefore we have to be prepared for that. Then last is our diabetes, gestational diabetes mellitus, which we are going to talk about hyperglycemia. That is also very, very important. Now it has been universally, you have to screen because we know the, problems with the hyperglycemia. So today's topic are fantastic. We have excellent, eminent speakers and the chairperson, moderators, and the panelists who are going to enlighten us on these very basic topics, which will going to help us in day-to-day practice, and in turn, which will help our women. So I really congratulate for the most apt webinar to Ranchi OBGY Society and wishing you best luck. At the end, I would like to mention about Nelson Mandela, quote by Nelson Mandela: "The education is best weapon when used can change the world." So let us use our education, update your education, and change the world by giving best to our women. Thank you once again for giving me this opportunity.
Thank you, madam.
Thank
you, madam.
For
Thank you,
your
madam.
words.
Shall I say a few words?
Yes, yes.
Yeah, Archana, please. Thank you, madam, for the great message by you. And I just wanted to congratulate you and Shanta, madam, because I have just attended the Respectful Abortion Care module from Foxy. It was one of the best module I have ever followed. Thank you, madam. Thank you very much for the Foxy's initiative. And great. Thank you, madam.
Archana, you are muted, huh?
Yes. Thank you, ma'am, for your blessings and inspirational words. And now I welcome Dr. Ajay Mane sir, who is presently chairperson, website committee AMOX, and medical legal expert, academician par excellence. And sir is also contesting for the post of Vice President Foxy West Zone. My best wishes to you, sir. I request you to kindly introduce our all three chief guests, our three guests of honor, to give few words of blessings.
Yeah, please. Can I have the slides, please? Yeah, the first and foremost guest of honor is Dr. Ashwat Kumar, who is a very good friend of all of us, a very thorough gentleman, very good academician, stalwart personality from Foxy. He's having diploma in advanced laparoscopy from France, diploma in laparoscopic management of advanced endometriosis in Australia, then diploma in laparoscopic management in gynec malignancies, IRCAD, Strasbourg, then fellow gynae oncology, GCRI, professor, Department of Gynecology, Jubilee Mission Medical College, Thrissur, Kerala. I wish to send my son to his college to get educated from him. He is such a knowledgeable person. He is ISOG Governing Council member 21-23, IAG Managing Committee member 21-23. Then Foxy Quiz Committee chairperson 2012-15. On demand, he has made a chairperson of Foxy Quiz Committee. Then he was Vice President Foxy 2019, Vice President KFOG 2017, past Secretary General KFOG Then the awards with his credit, Dr. D.C. Datta Prize for Best Publication in 19, C.S. Don Prize for Best Presentation in AICUG in 2006, then Sioli Rudra Sinha Prize Best Paper in Endoscopy AICUG Patna, Pride of Foxy Award in 2019, Foxy Sun Traveling Fellowship Award 2018, and many awards are not mentioned here. I know he has got plenty of awards with him. And he has authored 15 books and written chapters in many books, published articles in many national and international journals, delivered 10 orations and more than 200 faculty presentations, operating faculty in many national and state level conferences. A great human being from Foxy and South India, the greatest person on the academic horizon, Dr. Ashwath Kumar. I request him. I welcome Ashwath Kumar and request you to place us.
First of all, thank you for mentioning all these things. Basically, I like to be mentioned as a Foxian. That is what for all of you. And as a friend of all of you in the Foxy. First of all, I thank Ranchi OBGYN Society for making me a guest of honor with Pardeshi sir, and who I respect the most, and Maya madam from Ranchi, the past president of OBGYN Society of Ranchi. I thank Suman madam for conducting such a useful program. Actually, an overview, everything is well explained by Madhuri Patel madam. So very well. So nothing more to tell about. So respected all the seniors sitting here. From in Kerala, the so many seniors are there, and Ranchi also, like Maya Varma in Kerala, you have Prasanna madam, Jyoti Chandran, and we have so many Kerala also, so many seniors are there, plus our Dr. Geeta, Dr. Premila, Shaija, Subhash, everybody is there here. And you have so many other speakers also here. You can have Sujit is there, Dr. Sujit is there, and you have a finally and very expert panel with Dr. Sangeeta Menon and Suman Sinha madam herself. Something I should tell is that this corona has given us a lot of opportunities to meet each other. Okay, academics is one type. See, otherwise, how we from now the Kerala, all the people know all of you in Ranchi society. So, and you know most of the prominent people in Kerala also in most of the societies, at least the president and secretaries. So, and I'm not taking it long, but I just wanted to mention about two people in advance actually. One is Suman Sinha madam itself, both of them, and other is Ajay Mane sir. Both of them I know for years actually. In Foxy, they are hardcore workers, basic, they work for Foxy. So they have to be in the leadership in the future also. So I wish Suman Sinha madam, she is an excellent orator and a clinical research, and she has chosen the best committee for her election. So those who are, she will be if she wins, if we support her and wins, it will be always a treasure for Foxy also, not that opposite. It will be, we all need people like Suman Sinha madam in Foxy. And Ajay Mane sir, you all know, he has been to chairperson and he has worked so well. So now it is next turn to become the vice president. It's a stepping stone for the future presidentship itself. So naturally, we will all support both of them. That is what, and all the best for both of them. Okay. Thank you so much. Thank you everybody for again inviting me and making me a guest of honor for today's program. Thank you.
Yes. Thank you.
Thank you so much, sir. Ashwath. Thank you for the blessings. Thank you, sir.
Thank you, Ashwath, sir. You are always a guest of honor for all of us.
Yes.
So now we move on to next guest of honor. Can I have the CV, please? Yeah, none other than Rajan Singh Pardesi, who is my mentor. 27 papers presented and 6 times best paper awardee. He is ex-vice president Foxy, and he is incoming president of AMOGS. Then he has got prize as the best chairperson for Food and Drug Committee in 2012 to 14, and was a backbone for so many of the Foxians. And as Ashwath sir said, he is the person who is helping all the personalities who need help in Foxy. So I welcome Dr. Rajan Singh Pardesi sir and request him for the blessings.
Good evening, everybody. I am feeling proud and honored to be a part of this webinar. And the chief guest, Dr. Madhuri Patel, and she is motherly figure for us. And the guest of honor, respected guest of honor, Dr. Ashwath Kumar, Dr. Maya Verma, and Dr. Ajay Mane and Dr. Sinha. You have organized really a nice, fantastic webinar. I wish every success to Dr. Ajay Mane for his Vice President Foxy election and Dr. Suman Sinha for her chairpersonship. She is very active. I think she will be the next in the Foxy. Even Dr. Ajay, we want them in the Foxy. So I don't want to be in between you and scientific content. We are lagging behind schedule. I wish every success to this webinar. Thank you. Thank you so much. Thank you. Thank you so much.
Thank you, sir. Thank you so much.
Thank you, sir. Thank you very much for those blessings. Can I have the CV, please? Yes. And most senior, most guest of honor is Dr. Maya Verma, ma'am, who is retired professor and head of Department of Obstetrics and Gynecology, RIMS, Ranchi, and the Haldwani Medical College, Uttarakhand. She was external and internal examiner for UG, PG, PhD, and IGNO PAS, and she is past president of ROGS Ranchi and working as a senior consultant and CEO of her own nursing home in Ranchi, UPCHAAR. She is a very senior and academic personality, and she is a guiding force for so many people, including myself, and obviously Suman Sinha ma'am. So I welcome Dr. Maya ma'am, and I request for the blessings.
Hello, madam है ना madam? हाँ ठीक है madam. Thank you.
Madam was there, I think. Yeah.
Yes.
Ji, madam. I request you for the blessings.
Well, thank you, everyone. Thank you, the organizers, who has given me opportunity to feel happy by keeping me in making me guest of honor. I heard. First of all, I say good evening to all the dignitaries who are here, assembled here in such a day-to-day subject choosing for day-to-day. Yes. For selecting the subject which we face, all the practitioners face in everyday life of practice, say infertility, the role of endoscopy. You have many things, many knowledge, vast knowledge, but you have to know at what place your knowledge has to be applied. You cannot apply your whole knowledge in one patient. So that thing must be discussed. I think it will be discussed in the speech of this endoscopy in infertility. In the same way, the gestational diabetes becoming so much common, getting every few cases after that you will get in gestational diabetes. So the how to manage, how to investigate, what thing we must do. So awareness at the same time, the knowledge and the updated, though most of us read it every day, apply it in our patients, but it needs brushing, and every day new thing is coming that will be discussed in that chapter. So that subject has been included in our today's webinar. And of course this medical legal, it is running after obstetrician, though it is running after all the medical practice, but the obstetricians are the main target dealing with the two lives. So I think all the subjects are very burning, and it is helpful. It is facing, all the doctors are facing off and on these infertility cases, the medical legal aspect, the diabetes in pregnancy, and etc. So our Foxy Society is has given focus on these subjects, and that is the burning thing. And the audience, the delegates, and the newer persons who are entering in this profession will learn many things. And this, I want to say, this digital and the virtual program, it has enabled us to interact with all the societies of our country, in the international also. And when it was not possible for all of us to attend all the webinars or conferences occurring in the different parts, for many reasons, but this virtual conference has made everyone able to attain, to intermingle, to introduce oneself for each and others. And aim of our Foxy, the society, as very well enumerated by our General Secretary General Dr. Madhuri Patel. Each and every point she has elaborated. I don't think I should repeat all those points. What are the benefits of this society, what works, what is going on, what is important, everything. She has not left a single point. So how can I repeat all these things? One more thing I feel it is very important, that is the said by our president, Dr. Shanta Kumari. So we are all the Foxians are working and doing of their best by improving the health, the reducing the maternal mortality. But one thing, and this medical legal, one thing is very important, the safety. Safety, if you are not safe, you cannot do many things for the women folk. So safety is very important, and safety is not only required at our home. You feel safe when you are running in a folk of so many types of people, just like a rabbit running in the forest filled with the lions and the other dangerous animals. So a girl, a lady moves in the society, whether it is school, whether it is the outer area where she is going outside for reading, studying, or so whatever area that she is moving in the world like a warrior. So for there, they need safety, and that safety will not come from outside. We have to make ourselves very strong. With the knowledge as well as physical, I think physical health and physical strength is also needed. So that thing is included in our theme in our Foxy society. That is very thing. I think though Dr. Everyone has said very long speech, given long speech. I should stop it here. We're again thanking and saying good evening to all the dignitaries, thanking Dr. Suman, the Kerala Society, my own society, Dr. Kiran, who has invited me for this honorable post, for making me guest of honor in the place of so many enthusiastic workers. I am not very, though I want, but I cannot compete with their ability of work which they are, that Dr. Mane, Dr. Aswat, Dr. Shanta Kumari, Dr. Patel, and if all I saying, all the dignitaries are so devoted in the Foxy. I get a strength from them only. Though I'm old enough, even then, I get a strength from those. Thank you very, very much again. Thank you.
Thank you, madam. Thank you, madam. Your pearls of wisdom. Thank you.
Thank you, madam. See the humbleness of a lady, in spite of having such a guiding force and seniority and knowledge, and she is saying, madam, we go in front of you.
Thank you for your blessings, madam. We are honored, madam, for hearing.
Thank you.
Your blessings.
Thank you, madam. Thank you very much. And over to you, Archana ma'am.
Thank you so much, ma'am. It is indeed privileged to have their blessings. Thank you so much. Now we begin our scientific session with great speaker, Dr. Subhash Malya sir, on role of endoscopy in infertility. For this,
No.
I would.
Dr. Subhash has joined. He has joined. He has joined. Let me ask. He said he is there. Dr. Subhash, yes.
But Jyoti madam is waiting, no?
Okay. Dr. Subhash, what do you say? Will you go for the
fine, ma'am? I'll go third, ma'am. No issues. We'll finish up the first talk and I'll come
Subhash has come.
Anyway, Jyoti madam is waiting, so she has to go. We'll start with
Sujit.
Okay.
Okay.
Sorry, Subhash. Sorry for that.
Sorry, sir. So now our topic of discussion is on ultrasonographic features of early pregnancy, normal and abnormal. For this, I would like to introduce our chairperson, Dr. Jyoti Ramesh Chandran, madam. She is the President, Calicut Obstetrics and Gynecological Society of Indian Federation of Gynecological and Obstetrician of India from 2018 to 21. Vice President, Kerala Federation of Obs and Gynae Society of Kerala, 2018. Corresponding editor, Journal of Obs and Gynae Society of India, 2017 to 23. Member, Institutional Research Committee since 2016 to 21. And madam was PG thesis guide, assisted 20 postgraduates in thesis work, and she has received Javeri Essa Award at AICC RCOG 2021. With her to chair the session, we have Dr. Kiran Trivedi ma'am. She was ex-Joint Secretary Ranchi Ops and Gynae, ex-Treasurer ROCS 2019 to 21, and currently she is Secretary ROCS 2021 to 23 at present. And ma'am has presented various national and international conferences. Now I request Dr. Kiran Trivedi ma'am to kindly introduce our speaker, Dr. Sujit Kondkar sir.
Thank you, Archana. Very good evening to all the dignitaries present here. And it's my pleasure to introduce Dr. Sujit Kondkar. Previously also I heard her talk, and he is very clear in his work. So Dr. Sujit Kondkar is MBBS MD OBGY from GMC Aurangabad. He had done basic ultrasound training at Dr. Bimal Saini's Sonoscan Center, Aurangabad. FMF certified for many subjects, including fetal abnormalities. He is Joint Secretary of Society of Fetal Medicine, Maratha Wada chapter, and his center, Shri Hospital, is FOXI approved USG training center. He is interested in advanced ultrasonography, and today his talk is also about ultrasonography, normal in early pregnancy. So please, Dr. Sujit.
Shall I share my screen?
Before Dr. Sujit speaks, just let me have a few words. I would just like to thank Ranchi Society and Dr. Suman for inviting myself and my secretary to this wonderful webinar, and I would like to wish all the best to Dr. Suman for her candidature for clinical research committee, and all the best, Dr. Sujit, for your talk, because I've got to leave at 7 o'clock. I won't be there at the end of the talk, so wish you all the best.
Thank you. Shall I start?
Yes, sir.
Thank you for nice introduction and nice words. Good evening, all my friends, colleagues, and seniors. At the outset, I would like to thank Ranchi OBGY Society and Kerala OBGY Society for giving me this opportunity. Special thanks to Dr. Pardesi sir and Dr. Ajay Mane. The topic today is early pregnancy, ultrasonography of normal and abnormal or failed pregnancies. This is a very, very basic topic for obstetricians, because almost each and every obstetrician is having sonography machine at his center, and what the least they are doing is follicular study and early pregnancy. So concepts and knowledge about early pregnancy is very, very important for a smooth practice. So what is the agenda of early pregnancy scan? To confirm an intrauterine pregnancy and obviously to rule out features of extrauterine pregnancy. To date a pregnancy, this is very, very important, because dating done in early pregnancy is very much accurate than that done in later part of gestation. To confirm number and viability of the fetuses. To assess chorionicity and amnionicity in multiple pregnancies. To assess early fetal morphology and deviations from normal. This is a new concept in the imaging of early pregnancy. Everyone should be adapt to it. And to see maternal pelvic pathology, if any, because once the uterus is grown out of pelvis, these things are very difficult to visualize. Many are worried about the safety of ultrasonography in pregnancy. Ultrasound is quite safe. Transvaginal 2D is very safe. Even color flow mapping is very safe, but fetal spectral Doppler is questionable. So whenever you need to measure fetal heart rate in early pregnancy, always go for M mode and don't go for spectral Doppler. Remember, we still use the ALARA principle, that means as low as reasonably achievable. Some terms need to be clarified here. We call it as an embryo till 10 weeks. After 10 weeks, it is called as fetus. Abortion refers to patient's choice of terminating the pregnancy, and natural events are referred to as miscarriages. Some older terms need to be replaced by newer terms. For example, blighted ovum is an old term. It should be called as unembryonic pregnancy. Inevitable abortion is no longer used. Missed abortion is called as asymptomatic pregnancy loss, and so on. This table shows the older and newer terms, but the problem lies where most of the clinicians are using older terms and very few are using newer terms. So unless and until we speak the same language, the reporting will not be very uniform. Another important thing, EVS is the imaging modality of choice in evaluation of early pregnancy, obviously because of its highest resolution. Sonologists must be aware of normal and abnormal appearances of early pregnancy, and misunderstanding of normal anatomy and developmental milestones may lead to incorrect diagnosis and incorrect treatment, which is not acceptable. So after ovulation and fertilization, the blastocyst enters in the uterine cavity at around 4th to 5th day, and after 2 days, it gets implanted into the residua, giving a positive pregnancy test. So here the journey starts from non-recognizable ultramicroscopic and microscopic structures, which are very tiny, to a series of various C-shaped structures. Coming to this one, this is 8 weeks embryo. It is seemingly very large, but it is just 5 millimeter. So the first ultrasonographic sign of intrauterine pregnancy is intradecidual sign, which is seen at 4.5 weeks. It is seen as a small 2 millimeter size sac, which is eccentric to the central echogenic line and which has got a thin echogenic rim around. So this is a very beautiful sagittal image of the uterus. So we expect gestational sac to be in the upper part of the uterus and to either side of the midline. Next to come is double decidual sac sign. So decidua is the endometrium of first trimester. This sign is seen at 5 weeks, which is seen as a rounded or oval fluid collection surrounded by 2 echogenic rings. Outer ring is decidua and inner ring is chorion. So there are some pitfalls here. The pseudosac, which is seen in around 20 to 25% patients of ectopic pregnancies, can be mistaken as double decidual sac sign, but there are very differences. Pseudosac is elongated and centrally placed. It has got acute angles. It is teardrop shaped, and importantly, it is avascular. Small decidual cysts can also be mistaken for small gestational sac, that is intradecidual sac sign. But these cysts are well demarcated cysts in endometrium, and they are usually not abutting endometrial canal, and they don't have any echogenic rim. Then next to come is yolk sac. It is the first structure identified within the gestational sac. It is seen at 5 to 5.5 weeks, just 3 to 5 days prior to embryo. The positive pregnancy of this intrauterine pregnancy is 100% when you visualize the yolk sac. It is spherical in shape with echogenic periphery and sonolution center. The embryo is attached to this yolk sac with a white line duct from which it gets all the nutrients. The normal diameter of yolk sac is 2 millimeter at 6 weeks, and it is 6 millimeter at 10 weeks. In the early pregnancy, usually the number of yolk sacs corresponds with the number of amnions. These are the beautiful 3D images of yolk sacs. Yolk sacs in multiple pregnancy. So here in the first image, there are 2 yolk sacs. That means this is diamniotic pregnancy with clear lambda sign. This is diamniotic dichorionic pregnancy. In second image, you get 2 yolk sacs with a thin membrane T sign. This is diamniotic monochorionic pregnancy. This third image is 3D beautiful image having only single yolk sac. That means this is a monoamniotic monochorionic pregnancy. It is very important to remember that yolk sac size is not a parameter for assessing the gestational age. Then comes the cardiac flicker, which is seen at 6 to 6.5 weeks. Embryo appears like a little dot on yolk sac, which is called as diamond ring sign. Cardiac activity may be seen as a flickering in this area. This is how it looks. Then comes the amnion, which is seen at closure of 7 weeks. It is a thin membrane surrounding the embryo. This is the amnion. The embryo is in the amniotic cavity and the yolk sac is in the extraembryonic coelom. So at 7 to 9 weeks, amnion is expanding. The yolk sac is free floating in chorionic cavity. As continued growth and development progress, the embryo visibly changes from a dot to a grain of rice to a more kidney bean shaped structure. Embryonic morphology is better seen on 3D. This is 6 weeks embryo, already told. 7 weeks embryo is L-shaped. That means there is a right angle between head and body. The umbilical cord is somewhat thicker. limb buds are just emerging. 8 weeks embryo is open C-shaped. The limb buds are clearly seen. The umbilical cord has got very much thinner as compared to 7 weeks. After that, you got very nice protuberances of head and abdomen. Limbs are nicely developed. Many times you can get a small physiological hernia at the umbilicus, and this is the proper 10 weeks fetus. Now the embryo is renamed as fetus after 10 weeks. By the end of first trimester, organogenesis is complete. The amnion fuses with chorionids at around 14 to 16 weeks. It is very important to remember the order of appearance. First to come is intradecidual sac sign, then double decidual sac sign, then yolk sac, then fetal pole, then cardiac pulsations, and then amnion. It is important because in some abnormal pregnancies, this is disturbed. Now, there are 3 important measurements in early pregnancy. First is mean sac diameter, second is crown rump length, and fetal heart rate. Mean sac diameter is the mean of 3 orthogonal planes: longitudinal and anteroposterior diameter in sagittal plane and transverse diameter in transverse plane. Mean of 3 is mean sac diameter. In a normal, healthy growing early pregnancy, the rate of growth of gestational sac is about 1 millimeter per day. And the most important thing here to remember is do not use mean sac diameter for dating. Use only CRL. Measurement of CRL is very, very important because it is important for dating, and further it is used for diagnosis of fetal growth rate and all those conditions. So this is the ISO criteria. The fetus embryo should be midline sagittal. The orientation should be horizontal. It should not be oblique or vertical. Magnification should be such that the fetus have got the full screen. The position should be neutral. That means there should be some fluid between chin and the chest. It should not be hyperflexed or hyperextended. Ends point should be clearly defined so that your measurements are correct. ISOC also states that between 6 to 9 weeks, embryo is hyperflexed, so you can use neck rump length instead of crown rump length. As mentioned earlier, whenever you need to measure fetal heart rate, always go for M mode, never use Doppler. Heart rate is visible after CRL 2 to 4 millimeter. As shown in this graph, in the early phases of pregnancy, the fetal heart rate is somewhat on lower side. At 8 weeks, it is 145 to 170 beats per minute. And after 9 weeks, it plateaus to 137 to 140 beats per minute. Some terms need clarified here. In context to obstetrics, viable pregnancy means which can result in a live born baby. That means it should be more than 24 weeks. But when we talk of early pregnancy scan, strangely, early pregnancy viability means only intrauterine pregnancy plus demonstration of fetal cardiac activity. This is sufficient to name that is a viable pregnancy. Non-viable means which cannot result in live born baby, and intrauterine pregnancy of uncertain viability comes under the gray zone. So miscarriage is defined as spontaneous loss of pregnancy before it would be able to survive independently. So fundamental principle is first do no harm. So wrong diagnosis or mistaken diagnosis of failed pregnancy is not accepted. It should be taken as crime because it may lead to inadvertent termination of a potentially viable pregnancy. You should not be in hurry. You should not be in haste to label the pregnancy as failed pregnancy. There are strict cutoffs for diagnosis. Strict time intervals are there for repeat scans if initial scan is inconclusive. First, do no harm is the basic thing. There are some signs of early pregnancy failure. Some are definite signs which tells that surely this is a failed pregnancy. Some are worrisome. You can pay attention to them, but don't rely. Some are associated. They are less predictive. They are hard to apply. Definite signs are CRL based, mean sac diameter based, and time based criteria. When coming to CRL based criteria, when you see a crown rump length of 7 millimeter or more and no cardiac activity in that pole, you can straightway label it as a failed pregnancy. The previous cutoff was 5 millimeter, but it has been changed recently. When CRL is less than 7 millimeter, it is mostly demised, but you need to have follow-up scans. It is very important to be sure that you are imaging embryo only. Early embryo is at age of yolk sac. Two things can be mistaken for that: lobular wall of gestational sac and chorionic bump. This is a nice image of chorionic bump. This is the chorionic bump. This is the chorionic tissue. Inexperienced sonographer may take this as a fetal pole. can take measurement, you can put a mode, and obviously there is no activity here, it can be labeled as a miscarriage. This should be avoided. So in mean sac diameter based criteria, when the mean gestational sac diameter is more than 25 millimeter without embryo, then you can state label it as a failed pregnancy. Previous cutoff was 20 millimeter, but recently it has been updated. Mean sac diameter 16 to 24 millimeter is suspicious but not diagnostic. There is again new evidence. When the patient is having very regular cycles and even more than 70 days after LMP, if mean sac diameter is more than 18 millimeter without embryo and crown rump length is more than 3 millimeter without fetal heart activity, it is miscarriage. Remember that all this applies when you are using transvaginal scan. If because of any reason you are not able to do TVS and you are using transabdominal scanning, always call the patient after 14 days for the follow-up. Now coming to time-based criteria. CRL and mean sac based criteria are single scan. That means in the one sitting, you are giving the diagnosis of failed pregnancy, no follow-ups are required. But there are many pregnancies which do not reach the milestones of 7 or 25. So time-based criteria is for these patients. So when the initial scan shows gestational sac without yolk sac and embryo, follow-up for the patient after 15 days. If the initial scan shows yolk sac but no embryo, call the patient after 11 days. And even after this time period, there is no improvement, there is no cardiac activity, then you can label this as a failed pregnancy. Now, there are some suspicious findings which are not definitive. There are gray zone parameters, small sac size, empty amnion size, embryonic bradycardia, and expanded amnion sign. We'll see one by one. Gray zone parameters means where absent cardiac activity below cutoff of CRL 7 millimeter or mean sac diameter 16 to 24 millimeter. Here, time-based criteria is less than required. No cardiac activity or embryo on follow-up scans confirms the diagnosis. Now coming to oligoamniotic sac. Normally, gestational sac is considered to be larger than embryo. By and large, it is said that if you are able to put one more embryo into that gestational sac, that is the normal size gestational sac. This is a rough guideline. When the mean sac difference between mean sac diameter and crown rump length is less than 5 millimeter, it is called oligoamniotic sac. This is not a definite sign. You can suspect, you need to have follow-up. The normal order of appearance, as already we have discussed, is first come gestational sac, then yolk sac, then embryo, and lastly amnion. Here in empty amnion sign, amnion is seen but no embryo, which is abnormal, which carries poor prognosis. This could be mistaken for 2 yolk sac in monoamniotic monochorionic twins. Embryonic bradycardia is associated with adverse outcome. Severe bradycardia is associated with less than 1% survival rate. Embryonic cardiac activity is normally seen before amnion is seen, but in expanded amnion sign, there is visualization of embryo that is surrounded by amnion, which has got no cardiac activity. These are the some yolk sac abnormalities. Here, you can't see the yolk sac, that is absent yolk sac. This is the larger yolk sac, which is more than 7 millimeter. As already stated, the normal range of yolk sac diameter is 2 to 6 millimeters from 6 to 10 weeks. This is the calcified yolk sac. All these can be associated with adverse outcome, but these also are not definitive signs. You still need to have follow-up scans for your diagnosis. Irregular shape of gestational sac is also associated with unfavorable fetal outcome. Yes, this is very common. Subchorionic hematomas are very common. They are not significant. But if the hematoma is large, which crossing more than 2/3 of the sac circumference and gestational age is less than 8 weeks, you need to worry for that. Again, this is another finding. These are the echogenic lines seen in extraembryonic coelom. These echogenic lines, they are associated with abnormal or unfavorable fetal outcome, but many studies are not favoring this finding. Now coming to ectopic pregnancy, as all of us know, most of the ectopic pregnancies are tubal, and out of which 70% are ampullary. We are not going into details of the theoretical part. We are going for imaging part only. So in about 60% of patients, we get Bob sign, that is inhomogeneous adnexal mass. In 20% of cases, we get Bagel sign. And in 20% of cases, the diagnosis is straightway. You get an extract gestational sac with or without yolk sac, with or without embryo, with or without fetal cardiac activity. This is blob sign. So this is the ovary and this is the inhomogeneous adnexal mass. It is very important to remember that these two are separate. Here sliding sign is positive. That means with the help of probe, you try to separate these two are separate entities. This is seen in 60% of cases. Another is Bagel sign. Here is the ovary and here is the adnexal mass showing gestation sac here. This is seen in 20% of cases. In this third image, the diagnosis is very, very simple and straightforward. This is ovary and in adnexa, you are seeing the gestation sac with yolk sac with a fetal pole. This is hemoperitoneum. The amount of hemoperitoneum depends on the amount of bleed in the peritoneal cavity. By and large, anything going beyond the pouch of Douglas is supposed to be the severe variety of hemoperitoneum. There are various non-tubal ectopics like interstitial ectopic, cervical ectopic, ovarian ectopic, pregnancy in rudimentary horn, ectopic after hysterectomy. All these things are beyond scope of this talk. I would like to mention only two things. This is scar ectopic. Nowadays, this is lately has been very common. The four important characteristics of scar ectopic are empty uterine cavity, empty cervical cavity, gestation sac in the anterior myometrial segment, and very, very thin or absent myometrium anteriorly. It is very important to look into this because these are supposed to be the precursors of placenta acreta spectrum disorders. And another is heterotopy pregnancy. That means pregnancy, concurrent pregnancy, intrauterine as well as ectopic pregnancy. In natural cycles, the incidence of heterotopy pregnancy is 1 in 30,000. But in ART clinics, when you are assisted reproductive technologies there, the incidence is 1 in 4,000. It is very, very high. If you are transferring more than 4 to 5 embryos, it is again very high, 1 in 40. So whenever you are working or imaging in a busy ART clinic, you have to look very carefully at the adnexa for heterotopic pregnancies. This is on rise recently. Now coming to last part, complete mole. This is having very clear diagnosis, bunch of grapes or snowstorm appearance. Detection rate is 60%, more than 90% by sonography, as compared to only 25% which is seen in partial mole. In partial mole, you get some fetal tissue along with the molar tissue. So you have to think beyond cardiac activity, dating, and number of fetuses. You have to tune your mind to embryonic morphology. This is the new concept because at around 10 weeks with higher resolution images and newer machines, you can diagnose so many abnormalities at this stage also. For example, acrania, coloprosencephaly, ventriculomegaly, body stalk anomaly, and etc. There are some studies into it. Sonographic detection of fetal abnormalities before 11 weeks of gestation. NT studies have, nuchal translucency studies has been also done. Is nuchal translucency a useful aneuploidy marker in fetuses with crown rump length of 28 to 44 millimeter? This is the table of percentiles showing NT values before 45 centimeters. So these are the newer studies into the pipeline. So take home message, remember the chronology, order of appearance, because in abnormal cases, it is disturbed. Transvaginal sonography is the mainstay of imaging in early pregnancy. Don't be in a hurry or haste to label pregnancy as the failed pregnancy. Adequate follow-up scans are very, very important. And think beyond cardiac activity, dating, and number of fetuses. Look at the morphology. You can image many things, diagnose many things at 9 to 10 weeks of gestation also. Thank you for patient listening.
Thank you, sir, for the wonderful talk. Is Jyoti ma'am present here?
I think
she is not there. I think
she just left. There was a message. So Dr. Kiran can conclude.
So I request Dr. Kiran ma'am to kindly conclude the topic.
So Dr. Sujit has described everything very nicely. So the concept has changed from dating scan to abnormalities. So how to detect how to measure the crown rump length, what is the mean sac diameter, how to differentiate between viable and non-viable pregnancy, what is the importance of bradycardia and fetal heart, and most important, we should not use Doppler in initial first trimester scans. And what are the abnormalities, we can detect that anencephaly, hormone, and other whatever described by Dr. Sujit was very clear, and the pictures were very nice. So I think everyone who is present here will get benefit from this presentation. Thank you so much, Dr. Sujit, for your wonderful talk. Thank you.
Yes, I wanted to add to his biodata that he is having FOXI recognized training center, and he has trained almost 100 doctors, 100 gynecologists rather, from his center. He is such a good teacher.
Sir, where is he placed? Aurangabad only?
Yeah, he is in Aurangabad.
We'd like to learn from you, sir, if you give us some opportunity.
Yeah, he has got very beautiful videos and pictures, and in spite of having 100 patient plus OPD, he has come today.
So even minute thing he is describing very simply and nicely, that what are the precautions we should take during measurement, and what we should keep in our mind, so that we cannot miss the things which should be seen in first trimester. Thank you so much.
Very great teacher he is.
Yeah.
Over to Archana.
Thank you, sir. Now to start with the second session on the topic, Ask the Medical Legal Expert. For this, to chair the session, we have Dr. Pramila Menon, Madam. Madam is professor at Thrissur, Kerala, and she is the past treasurer Thrissur OBGY Society, past editor KFOG and TOGS. And ma'am has received Kamini Rao Orator 2017, Yuva All-Rounder, Yuva FOXI 2016. With her to chair the session, we have Dr. Saijus, sir. Sir is the chairperson, Midlife Management Committee of FOXI 21-24, Joint Secretary, Kerala Federation of Obs and Gynae 21-24, past chair, Research Committee of KFOG, President, Kannur, OBGY, Kannur, Kerala, and FOXI. Sir has received many awards to his credit. FOXI, Mrs. Salja Pandit Women Empowerment Award 2020, FOXI International Traveling Fellowship Award in 2019. FOXI
I think that would do. I think you can skip. We can go ahead.
Okay, sir. Sir, you have such a long list of achievements and designation. We are really privileged to have you, sir. And now I request you to kindly introduce our speaker, Dr. Ajay Mane, sir.
Yeah, thank you. Thank you. Thank you so much, Suman Madam, and best wishes for your tenure ahead. Thank you so much, Ranchi Society, for collaborating with the Kerala societies and for this opportunity. A little bit of network issue. That's why I thought I would be better, clear, or audio-wise, rather than switching on the video. I've just not reached back home after work. So apologies on that. Such a privilege to introduce Ajay Mane, sir, a very, very dear friend, much more than what is written on the CV slide. A member of the National Inspection and Monitoring Committee of PCPNDT wing of Government of India through FOXI, has been a medical legal consultant since 18 years, chairperson of the official EMOX website, the chairperson of the Sexual Medicine Committee of FOXI, with which he did a commendable work, chairperson of the Adolescent Health Education Committee 2012 to 14 and 2014 to 16, and a lot more. I think a real multifaceted person has worked not just on the academic front, but on the social front too, spreading awareness on some very, very key aspects. And he's dealing with a very, very important topic today on asking the medical legal expert. I think the way things are going now, it is much better to marry a medical legal expert if you happen to be a gynecologist, because there are so many issues, isn't it? Better to have one at home. Otherwise, you should have the visiting card of somebody like Dr. Ajay Mane just under your pillow as you go to sleep, because these are the only two options left, I believe, with the increasing number of medical legal issues that we are facing today. So with those words, all the very best to Ajay Mane, sir, for his West Presidential Vice Presidentship, West Zonal Vice Presidentship, I would say, on the elections that are coming up. And to Suman Madam for your future endeavors. Over to Ajay Mane, sir, for your lecture.
Thank you, Sajay sir. I am overwhelmed by your words and the style of introduction. You are SP Balasubramaniam for all of us. I have heard you singing. Yeah. Yeah, his voice is very much similar to SP Balasubramanian. He sings very
Yes.
nice, very nice.
Very nice.
So, and we can see your boxing pose on your DP. Thank you. A commendable job. Thank you, Shajesh sir. And thank you, Suman Sinha ma'am and
Thank you, sir.
Trivedi madam and Ranchu Vision Society to give me chance here. Now I'll move fast because we are lagging behind. So I'll be rushing through slides, not explaining every detail. Okay, fine. Today's topic is Ask the Medical Expert in day-to-day obstetric practice. So certain questions came to me and certain situations faced by other my colleagues I have incorporated in this presentation. So this is a but you have heard. Gratitude to Dr. Madhuri Patel ma'am, Dr. Rajan Singh Pardesh sir, Ashwath Kumar and Maya Verma madam, such a senior fellow, such a humble personalities, all of them. They have given time for the webinar. Then Dr. Suman Sinha ma'am, Dr. Kiran Trivedi ma'am, and Archana Pathak, MOC, and the Rancho Vision Society for giving me chance. Mainly the Trivandrum, Adur, Thrissur, Calicut, Kannur, Kollam, Kottayam, and Kasaragod Vision Societies from Kerala. Thank you very much for accepting us in your societies. Dr. Subhash Malya, who is my very near and dear friend, with Dr. Sujit Kondkar, who is been my classmate, and Dr. Shaijesh, very near and dear friend and family member, again from Kerala. Thank you very much for being there, and Kerala Association of Vision Societies, and all chairpersons, particularly Dr. Pramila Menon ma'am, Dr. Prasanna Kumari ma'am, Dr. Rekha Jha ma'am, Dr. Jyoti Ramesh ma'am, Dr. Sangeeta Menon ma'am, Dr. Geeta AP ma'am, Dr. Simi Kurian ma'am, Dr. Minu Priya ma'am, Dr. Rani Lakshmi ma'am, I like the name basically, Jasi Kirani, then Dr. Deepa Madhavan ma'am, Dr. Deepthi PS ma'am, Dr. Reena Godasara ma'am, all the delegates. Thank you very much for giving me the chance. Now, we'll come to the presentation. Situations. Patient came with a pregnancy of 17 weeks for first time and her age is 17 years. What next? If a patient come like this into your OPD, what you will be doing? You will be doing the thing properly, which is concerned with the POXO Act. Why? Because her age is 17 years. A person coming, rather a woman or girl coming to your OPD with a pregnancy who is less than 18 years completed, huh? Not started. 17 completed, 18 started is not an adult. Definition of adult by law is 18 years completed. So if she is 17 years, you need to inform the police or the child welfare committee in written format and have a receipt with you and then proceed further. You don't have to wait for the police to come into action. But since this is not a life-threatening condition, we can wait for the police to come, have a statement and go for the termination or ANC checkup, whatnot. And here, the marital status do not make any difference. Though she is married, though she is unmarried, you need to inform police. Clear? Fine. Follow protocols. I have told you the protocols and documentation. What is documentation? Give the information to the police in a written format. Have a receipt from them. You have, that is the dangerous situation. And if you have informed on phone, keep a recording. If you have informed on mail, keep the mail with you. Okay, and whatnot. But all documentation must be with you. Then next situation, registered patient came in early labor, unregistered patient. Okay, so we are not having moral duty to accept the patient. Okay, that's why I have particularly given this unregistered. If she is registered, you are bound to get the patient admitted in the hospital. Okay, unregistered patient came in early labor, not ready for any investigations. Many times it happens and ask for admissions and delivery. Can we deny? Yes, because she is in early labor. So very early labor just started within a 1 hour, 1 or 2 pains coming. At that moment, she can be denied. Okay, unless and until life-threatening conditions are there, you can deny the patient. That is your right. You can deny the patient. As all of them said, 82% of the medical legal cases are faced by only and only obstetrician and gynecologist. Rest are in 18%. See, means the heart surgeon, the transplant surgeon, they are not facing such a huge medical legal calamities. We are facing 82%. Okay. So we can deny the patient, send with the proper documentation, a referral sheet with all details written, what primary things you have done to her, consent of going out, and referral letter to the concerned center, maybe higher center or maybe government center. Next situation, Registered patient with a routine follow-up. Okay, registered patient. This is not unregistered. Registered patient with a routine follow-up came at full term in labor and insisting for normal delivery only, and not ready for CS if needed, as the fetal heart rate is fluctuating, maybe less than 120, more than 160 or whatnot. Maybe at times, she has given history, sir, wo kabhi hilta hai, kabhi 3 din nahi hil raha ho, since morning. Likewise, if it is a dangerous condition, then you need to have sonography and heart rate and all the things. But she is not ready for CS if required. And insisting for the nahi, abhi normally karo, jo bhi hoga, whatever consequences are there, will be responsible for that. Orally they can say this, but if something goes wrong afterward, they deny. Nahi, we have told doctor that follow your instructions, go by your mind, but he only has waited till this condition. Likewise it happens. So what is the remedy? Record proper findings. Have a partogram. Partogram is a legal document. In one look, you can have the descent, the dilatation, the construction, the contractions, and the fetal conditions, the blood pressure, the meconium condition. Everything you can have in one look, and depending on that, you can prove that this was the condition. At this moment, we advised cesarean section, but patient denied, given this negative consent. And what is negative consent? That patient is not ready for cesarean section, and whatever the consequences the patient is ready to face is the negative consent. हम तैयार नहीं है ये करने के लिए. Whatever you want to, whatever the consequences are there, we are responsible for that. Get it written from. Have a signature, have a left thumb impression, have a habit of having left thumb impression besides every signature. The patient may say, "Are sir, we are educated, we can sign." Yes, you are educated, you can sign, but we need a left thumb impression of a right-handed person and a right thumb impression of a left-handed person. Why? Because they may deny the signature. This signature do not belong to me. Dr. Ajay Mane or Dr. Saijas has made a forgery, and his nursing staff has done the signature. I have not done the signature, but they cannot deny the thumb impression, because in 10 lakh and 15 lakh, one thumb impression matches to other. So we can prove that this thumb impression belongs to this fellow or this woman. So the signature belongs to this woman. This is first thing. Second thing, if the patient is educated, ask the patient to write down her name below the signature, and ask the witness to write down his name, maybe a male or female, whosoever, below the signature. Why? They cannot deny that the handwriting do not belong to them. In court of law, we can go to handwriting expert and prove that this signature, this handwriting belong to the same person, so the signature belong to the same person. These are the tips from my side. Okay, follow this and make it a routine that your staff should not forget to do that, all the things. Okay, then what we should retain? Fetal record, CTG, all the strips and all the, if it is a electronic only, save the recording and have a CD done with you, because sometimes the soft copy may get corrupted. Fine. The negative consent, I told you about that. And refer with all protocol, means referral letter, where are going, call there, the patient is coming, such and such situation, and all the things. Okay. Next situation. Patient not progressing well in labor and not ready for section. This is a routine, and not ready to shift also. We are not going to any hospital. I'm your regular patient. You are my family doctor, and I'm going to deliver here only, and deliver only, not cesarean section. Then what? That is dharma sankat for the obstetrician. And when you are working in a single doctor hospital setup, which we have, we are not working in corporate hospital. That is very easy. Counselor is there, the medical legal consultant is there, the manager is there, all come together. But in our setup, we are the only person performing all duties, as Madhuri ma'am said. We are everybody. We are sonologists, we are doctor, we are nursing staff, we are administrator, everybody. So what? Again, all records. What I told you, all the records, every condition must be recorded. Partogram is best. Follow partogram. It is not that partogram must be kept by only institution or the medical colleges. We all should keep the partogram. It is a legal document. You can produce in the court of law. We have two cases where we showed the partogram to the judge, and we can defend our side. Sir, this was the finding of partogram and this was the condition. So we won. Okay. Denial of shifting and negative consent must be taken in proper format, and then send the patient. And second opinion is very important. Why? Because when two consultants say a same thing, it is taken for granted that it is correct academic wise also. So take a second opinion, maybe a senior person, maybe a junior person who is a colleague and who is qualified. Okay, who is qualified. Don't take the second opinion of MBBS person. You need to have a qualification of at least degree, diploma in OBGYN, maybe senior or junior. Next position. Hand prolapse. Patient came with a hand prolapse in labor. What is next step regarding documentation? Everything you have to go for the cesarean section, emergency section. They counsel about the consequences and document it. What consequences? All Erb's palsy, brachial plexus injuries, whatnot, then gangrene and all the things. Then signature of the witness is very important because in that condition, patient cannot give consent. So consent for the procedure is taken and the consent is given by the near relative or whosoever is accompanying the patient. This is accepted in such conditions. Because patient in labor, patient is bad condition, patient is under anesthesia, patient is under drug or medicine influence, cannot give the consent. It is invalid consent. So at this procedure, at this time, take the consent of near relative. Indian Penal Code 88 accepts that their relative in good faith can give the consent. Okay, pediatrician must be present during procedure. Fortunately, nowadays we all are having practice of having pediatrician in normal labor also. That is a good thing that we are having one expert with us and who is opining and treating the patient that shares the responsibility. And if something goes wrong, we can say that no, pediatrician was there, so he is qualified person, so nothing was missed according to the protocols and everything is done. So pediatrician is must. Then take proper consultation of other fraternity, maybe a neurologist or maybe orthopedic surgeon, whatever, and document it. Whatever you do, document it. If you have done 10 things and you have documented 8 things, then it is considered that you have done 8 things. These 2 things which you have not written on the paper is considered as not done. So mind it. लिखना सीखिए, लिखना सीखिए, लिखना सीखिए. मैं घर पे जाने के बाद बीवी को बोलता हूँ, please give me dinner. I write it down. Please give me dinner. Just on lighter note, forget it. Next, what is called cord prolapse. Okay, cord prolapse patient come to you. Then again, emergency section, you have to put back the weight mop and hand and the cord positions. Just take care not to compress between pelvis and the head and all the things. So counsel about consequences and document it. Again, same thing. Signature of witness is there. Consent of procedure. Pediatrician keep all records and refer baby immediately to NICU. Though it is a normal baby. Normal, crying, Afghar score 9, 10, whatnot. But shift to NICU, shift to NICU at least for 24 hours for observation. And then only get the baby to the mother. Okay. Then IUFD, it is very dangerous condition. Patient comes, sir, wo sabri se soi raha hai, hil nahi raha. And when we find that it is a IUFD. 2 cases my colleagues always tell that CMO who has attended the IUFD and done the sonography did not tell that it is IUFD and send the patient to other hospital. And there they declare patient who have a IUFD. Means during journey, the baby has gone. And they allege कि वहाँ गया तो it was there. They did not tell anything about that death of the baby. And this fellow told means during journey, this is negligence on the first hospital. So do not do this. If you find a IUFD, tell at that moment with a due precautions. Such and such situation has happened. The baby is not there. The persons are not there. We are doing it on 1 or 2. Take another opinion. Ask your colleague or a senior fellow to come or junior fellow to come. Take the opinion again, and both of you must counsel the patient and relative that such and such thing can happen. It is IUFD and go for the further. So G3, P3, G4, P3, L0, type 2 diabetes mellitus, very chronic patient, present at 39 weeks with IUFD on admission. And from this situation, what is the message? Did not come for checkup as advised. This is the contributor negligence on the patient's side. Why contributor negligence? Because you have advised regular checkup, patient document it, patient did not come, did not get blood sugar done early, document it, patient not advised, rather followed the instructions, did not take insulin as advised, then again contributor negligence from patient part, document it, did not maintain fetal movement count as advised, document it, so you are free. This is a contributor negligence. What is a contributor negligence? It is a negligence on the part of patient, and contributor negligence is always beneficial to the doctors because it denies that you have followed your duties, the patient has not followed his her duties. So it is a contributory negligence on the part of patient and you are free. There is no charge of negligence. Again, IUFD document patient's non-compliance in the outpatient record. Primary with severe PIH, present at 39 weeks with IUFD on admission. Okay. Did not come for checkup as advised, document. You have already document. Whatever you give advice orally should write on the paper. It should not be like that. Every advice you should take a counter signature of the patient. No. Whatever you have written on the paper is considered as correct because you are an expert. So you are not going to write anything in bad intention. So whatever you write is correct. It is considered by the law. Did not get blood pressure checked regularly, documented. Did not take treatment as advised, documented. Did not maintain fetal movement count, documented, and you are free. Okay. Then again, next situation. Patient is in PPH, okay, bleeding, and you have not done the blood grouping prior, as patient was your regular one in ENS. Is this a negligence? Is this a negligence? Yes, obviously it is negligence because patient is your regular patient, no? At first visit only, you should have blood grouping done. And then only, though positive, AR is positive, AR is negative, whatever positive or negative, but blood group should be done on the first visit only. It is a protocol basically. So you have not done and patient is in PPH. So you are wasting time. See, 3 liters in 10 minutes. So that can be the rate of PPH in severe PPH. So patient is washed out completely and that is your negligence. Is it a negligence? Yes, it is a negligence. If patient is saved, then it becomes a civil negligence. If patient is gone, then it becomes a criminal negligence because the severity of the negligence depends, the criminal and civil liability depends on the severity of the negligence. You have done a gross mistake, then it becomes a criminal negligence. Say for an example, from orthopedic point of view, the injury or the operation was to be done on right leg and the surgeon operates on left leg. That is a criminal negligence basically. And civil negligence, the civil negligence results in compensation only. Criminal negligence results in compensation plus imprisonment. 2 years imprisonment is there. Okay. Question. Do we need to change? Okay. Now we come out of obstetric conditions. Do we need to change our MTB registration certificate from approved authority as change from 20 weeks to 24 weeks? No. It is considered that the 20 weeks word is replaced with 24 weeks and you did not reapply. But one question was there in respectful abortion care services just now. If the person is having one first abortion service with the hospital and now they wanted to start second trimester abortion, are they liable for the reapplication? Yes, they must reapply. But in such situation where they have got already 20 weeks registration, they need not apply. Fine. Okay. Can we sorry? Can we terminate pregnancy after 24 weeks and after 28 weeks? Yes, obviously the new amendment has given a right to terminate the pregnancy up to 24 weeks by 2 doctors' opinion. It was previously 12 to 20 weeks, 2 opinion. Now up to 20 weeks, it is 1 doctor opinion. Up to 20 to 24 weeks, now we need 2 opinions. And after 24 weeks, we can terminate the pregnancy, but after going to the medical court. Fine. Is failure of contraception available after 20 weeks up to 24 weeks? No. The clause number 5, which is there in opinion form, failure of contraception is available up to 20 weeks only, not beyond 20 weeks. Beyond 20 weeks only, few cases, rape, then marital status changes, widowed, or the congenital abnormality. Those are the conditions. But failure of contraception is not available after 20 weeks. But one change is there. Failure of contraception was available only for married women before this amendment. But in amendment, we get the chance to give this opinion or clause for unmarried also. Okay. So, in case of USG performer is different, can owner of USG sign? No. Is USG mandatory before MTP? No. It is not mandatory by law. But I tell you 2 good things about USG. It tells you about that Sujay sir just mentioned that the percentage of heterotopic pregnancies are increasing day by day. So if you have a heterotopic pregnancy, you give medical line of method for the MTP, then the tube is going to burst. Or ectopic pregnancy is there, you don't know the situation. Basically, you think that it is intrauterine, it is ectopic, it is going to rupture and having the PPH. And so this site of the pregnancy is told by the sonography confirmatory. And second, the gestational age, maybe 6 weeks, 12 weeks, a borderline. You are told about that it is 11 to 12 weeks and proved to be 14 weeks, and you are having only first trimester abortion center permission, then you are at problem. Likewise, so it is advisable, not mandatory. Is it mandatory to mention missed abortion, incomplete abortion, inevitable abortion, and plighted ovum in MTP? It is incomplete. In MTP, no. Basically, they do not come under purview of MTP. They are obstetric complications. They need to be mentioned in obstetric complication, but you need to have a separate consent, indoor paper, procedure notes, everything is to be maintained in a separate format, routine indoor paper, but not in MTP. Okay. Then which are the documents in PCP? It is very big question, man. I have given the answer. Form A, Form B. A is application, B is certificate, C is reason for refusal, D genetic counseling center, E is genetic laboratory where chromosomes are being treated or played. Form F, online form F, we all film. Form G is for invasive procedure, amniocentesis and Korean villus biopsy for them. Form G is there. Form H is for authorities. They have to maintain a record from all the centers. That is Form H. Tell us detail about Form F. No, it is very long. We'll skip this. Okay, there are 4 sections. A, B, C, D. A is detail, the name, age, sex, address. B is non-invasive, C is invasive, and D is declaration. Okay, that can I tell you. Amendment in 2003. How to sell a machine? Can we sell our machine directly to doctor or any non-medical person? No. We cannot sell our machine to any person. We can sell our machine to the person who is having a recognized, registered PCP center with him. Maybe a medical or a non-medical. Maybe a billionaire may have 2 sonography centers with a higher end machines. He may have, but he is owner. But he may have Sujit Kondkar's and Dr. Saij's name there as a radiologist or the sonologist over there, rather particularly sonologist. And in there, he can have a center, but we can sell the machine to the registered center only. We cannot sell to anybody. Machine scrapping, what is the new strategy? Now in 2019 amendment, they have given that abandoned machines, because previously many of us who are senior to me also, they were having small machine of Aloka and whatnot. And nowadays they are abandoned, new machines are taken, new machines are purchased, and the old machines, nobody want to keep them. So they have been kept in the sonography center with voluntary sealing, and but we need to send a 0 report for that closed machine to center every month. That is mandatory. So that was a very big problem. So we have pursued, the FOXI has pursued, and now the government has come with the amendment in 2019 that abandoned machines must be handed over to the appropriate authority, district appropriate authority. In Kerala and Tamil Nadu, they are having, I think, joint director, and we are having civil surgeon at district level. Okay. To them, and have a received copy that Dr. Ajay Mane has given 1 machine for the condemnation. Have a received, I am free. The duty of appropriate authority is there to either give that machine to the destruction center, to the appropriate authority, what are the sonography machine experts, or the government, or dismantling, whatnot. But we are free. What are the penalties under violation of PCP Act? Then you know, it is a cognizable, non-bailable, and non-compatible. I'll explain the terms. Cognizable means the investigating officer may come to your OPD or to your hospital and start investigating without any warrant or without any order from the judge. That is a cognizable. On his own or on her own, that investigating officer may start investigation and he or she may arrest you. That is a cognizable. So MTP and PCP both are cognizable. Non-bailable means you can get the bail on this condition, but in non-bailable condition discharges, you need to get the bill from the magistrate. The police take you, keep in the chowki, then they present to you or produce to you in front of the magistrate, and the magistrate grants the bail. But in bailable, you get the bail at chowki. Okay, this is the difference. And non-compoundable, once the case is filed, it has to go till the end. No out-of-court settlement is possible in non-compoundable. So it is a very dangerous thing. Then 10,000, 50,000, 2 year to 7 year imprisonment in everything is there in PCP and MTP. What is the difference between PCP and MTP? One consultant may have many which is not possible for PCPNDT. Only 2 centers in one district by name. Sujit Konkar may have 2 centers in Aurangabad, and he may have 2 centers in Jalna, which is 50 kilometers away from this place. But the timing must be displayed at each and every clinic. That 10 to 2 is Aurangabad, and then maybe 4 to 6 is Jalna. Likewise, it can be there. One may perform MTP at any recognized center. I can go to Suman Sinha ma'am's center and perform MTP as I am recognized person. Center is recognized, patient is proper, but I need to inform the state appropriate authority that the state is changing. No, and if it is within the state, you need not mention or inform anybody. No regular inspection mentioned in law for MTP, but every 3 months PCPNDT must be inspected. No renewal for MTP, but PCPNDT every 5 years you need to take the renewal with the 50% fees. Say for an example, for sonography center it is 25,000. For renewal it is 12,500. If it is a ART center and sonography center, you need to pay 35,000 at starting and 17,500 at renewal. Okay. For MTP, it is one-time fees. Okay. Place approved or not restrictions. So non-bailable, cognizable. Okay. Rigorous imprisonment for 2 to 7 years and fine. And MTP record must be kept for 5 years. PCPNDT record must be kept for 2 years. Okay. So anticipate proper documentation, keep blood ready for cross match, especially in RH negative. Follow protocols, then follow protocols. Which protocols? FOXI, ICOG, ACOG, WHO, or RCOG. And because if you follow protocols, you are not at fault. The fate of the patient, the output of the treatment is not in your hand. You can go with the protocol, and if something goes wrong, you can produce. These are my papers. These are the protocols, and I have gone with the protocols, so you are free. You are not negligent. Likewise, so follow the protocol. So you need to have all protocols attached and go for according to the protocols. Okay. All consent paper with proper procedure, legitimate record. Don't scratch it. Just have a single line and don't overwrite it. And give the numbers to the papers 1, 2, 3, 4, 5 and write upper part. Whenever you give the paper to the police or the patient, patient can demand the papers. It is right of the patient to demand the patient papers to you. You need to give within 36 hours. Rather, when the police ask, you can give within 36 hours, and when the patient asks, you can give within 72 hours. Okay. So have a photocopy of those poor complete branch with you and then give it. Original paper must be written with you. Don't give original paper, give photocopy. Fine. What is the take home message? Follow all protocol, document well, keep trained staff, training and drills regularly, because your staff may run here and there in emergency. So they should have a proper drill and training. Have a system in hospital, working pattern, and keep good relation with the colleagues and help them, because they are the only person who will help you in your bad condition. And if needed, I'm there. I'm there for advice also. In bad condition only, you should not call me. You should call one patient is coming, what should I do? Or the inspector is asking for the paper, what should I do? The inspector is calling me in the police station, what should I do? Shall I go or not? This can be answered by me. This is my number. Kindly save this number to get the medical legal tips regularly on your phone. So kindly save this number by my name. Thank you very much. And it is completely free of cost. Since 18 years, I'm doing this. It is completely free of cost. And I am treating Army, Navy, Air Force personnel with their first blood relation free of cost since 21 years. That is my duty. That is my duty for this nation. This is women empowerment in Israel, carrying a gun for herself. And this is women empowerment in India. Salute to Dr. Captain Deepashika Chetri. She is in China Glacier today. She is a surgeon. Having salute to these workers. They have completed a great task. Salute to these workers, completed a great task for India. And this is my sincere request to you to kindly vote for me for the post of Vice President West Zone. There are 2 posts in West Zone. One I request for the one post, and second is your choice. So kindly vote for me. As Ashwat sir, Shailesh sir, Subhash sir, everybody has blessed me. Thank you, Verma madam also, and Madhu madam also for your blessings. And again, thank you, Sumanji and Rancho Vision Society. When they can stay together, why can't we? So help your colleagues, right? Thank you. Thank you very much for giving me the chance.
All the best, sir. All the best.
Thank you, madam. Thank you.
Thank you so much, sir. Your talk was really very insightful, and my best wishes to you, sir, again. And I request our chairperson, Dr. Pramila ma'am, to kindly give the concluding remarks.
So thank you, sir, for that excellent presentation. It was really good. I think you covered all the points very nicely. All the it's have covered very nicely. You have covered, and I don't think there would be much queries. But I thought one query actually came into my mind when I heard this. Suppose nowadays, after 24 weeks, many people are getting court orders and getting MTPs done. So do we do feticide for them? Or else suppose the
No.
baby is born live and the baby is alive, what will we do?
Yes, the correct question you have asked. We are facing so much problem that feticide that is our demand to the government, that kindly give us permission for the feticide, because we cannot see a baby moving there, which is an abortus. Basically, before 28 weeks, we can say it abortus, but nowadays they are having court orders, but now forward onwards, they don't have to have court orders. The medical board is there at all district levels, but this problem is faced very much in past, and in future also we are going to face it very much. So as you correctly said, we are requesting government to kindly give us the permission to have a feticide first and then the abortion process. At present, we are not doing feticide. It is not allowed. Thank you, madam. Thank you,
sir. Thank you for clearing that. And all the best for your elections. And thank you, Suman madam and Ranchi Society for inviting us. Thank you so much. All the best. Thank you.
Thank you.
Over to Archana, ma'am.
Thank you, ma'am. Our next session is on role of endoscopy in infertility. To chair this session, we have Dr. Prasanna Kumari, ma'am. She is a senior consultant obstetrician and gynecologist and head of department in Lifeline Hospital, Ador, and senior consultant obstetrician and gynecologist, SUT Hospital, Trivandrum. And she is the author of the book Postgraduate Gynecology, awarded WHO Fellowship in 1991, and she was the past president of KFOG. To chair with her, we have Dr. Rekha Jha, madam. She is the president, Bhagalpur Ops and Gynae Society, a member, Public Awareness Committee, FOXY, and a member of Rotary Club. And she is secretary, Bhagalpur Ops and Gynae Society in 2002. And she is the chairman, Diabetes Society, Lions Club of Silk City, patron, Jeevan Jagriti Society, Bhagalpur, and Chief Health Officer, International Human Rights and Anti-Corruption Bureau, India. I request Dr. Rekha Jha, ma'am, to kindly introduce our speaker, Dr. K. Shubhas Malya, sir.
So a very good evening, everybody. And I thank the organizers, the Kerala Society and the Ranchi Society for giving me the opportunity to become a chairperson in such a beautiful webinar of mixed bags, because the medico-legal issues that the tips Dr. Ajay gave was very good, and also the ultrasound pictures presented by Dr. Sujit was wonderful. He had made it very interesting. So even though I don't know much about ultrasound, I was hooked to the screen for the full session. And now coming to Dr. Subhash, who is chairperson endoscopy committee of FOGSI. Dr. Subhash, he has a real charming and smiling personality. His smiling face on the flyer is really something very attractive. So Dr. Subhash, he is MBBS DGO, DNB, MN AMS and Diploma in Gynae Endoscopy, PVS Hospital and Baby Memorial Hospital, Calicut, Kerala. DNB Guide and Examiner at the National Board of Examinations, Delhi, and Chairperson FOGSI Endoscopy Committee 2124, Chairperson Medical Legal Committee KFOG 2124, and Secretary Calicut Society 220 onwards, Kerala chapter, IAGE 219 onwards, Managing Committee member IAGE 29 to 20, and FOGSI Mentor Mentee Award 2019. So he is going to speak on laparoscopy and infertility. So over to Dr. Subhash.
Thank you very much, Rekha Jha, madam, for those wonderful words. Sometimes some looks can be deceptive, ma'am.
No, not at all.
Not at all.
Not at all.
Thank you, ma'am. Thank you very much.
That's your smile.
I bring Warm greetings from Calicut and from my president and from the society. We are a 45-year-old society and we are doing pretty well. And I wish to take our society even higher. Now, coming on to the topic per se, yes, sir, is my.
Yeah, it's visible. So make it full.
No, that is something which I think off late we're having some problem. Somebody just guide me. I did know about that, but I.
Yes, sir. Shall I help you, sir?
Yeah, please, ma'am, please.
Sir, please stop share. Make it full screen and share again, sir.
Yeah. No, I've done full screen, but I cannot share it now.
Sir, you can go to Zoom. You can press Alt tab, put together. Alt tab.
Alt, yes.
Yes.
Now you can see the Zoom icon.
No, I 1 second. I have done a share screen. Yes, I've done share screen.
No, sir. No, sir, not.
Okay, Subhash, now I'll tell you. You have done
yeah.
share screen, na? Yeah, go for the bottom line, right?
No,
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 stop
please share.
share.
No, sir. Please share. I will take the control. Please share the screen again.
Yes, I've done that. Yes, I've done that.
No, sir, not it. We can't see the screen. Yes, sir. Started. Just accept my request, sir.
Proof. I've done that.
Yeah, thank you. Thank you so much, sir. I will just.
Yeah, thank you. Thanks a lot, ma'am. Thanks a lot.
Yeah, no problem, sir.
Right.
Sir,
This is greetings from Calicut. Thank you for that wonderful introduction.
Thank you.
Now, respected chairpersons, Dr. Rekha Jha madam and Professor Prasanna madam. Right. I mean, with all humility, I will show this is my first slide. I'm a cat in front of all these, with no respect, but these are all very senior. These are people who know a lot of subject. And I, with all my humility, would like to present all whatever data that I would have with me. Right. Now, as we all know, let me tell you, this is one topic that creates a lot of rift between the ERT specialists and the endoscopic surgeons or the laparoscopic surgeons. Because no offense meant, but then most of the ERT specialists feel that we endoscopic surgeons are very radical. We destroy the endometrium, we destroy the eggs, and we damage the tubes. That's something which we always, get a lot of criticism over. The theme of today's presentation is to collaborate between these two fraternities. It's the ERT specialists and the endoscopic surgeons, and work towards a common goal, that is achieving a pregnancy and of course a healthy one. That's why I said our aim is achieving pregnancy and a healthy one. Second is to review the guidelines pertaining to fertility enhancing surgeries that we have. And third is to share the tips and tricks in hysterolaparoscopy. That's how I would like to start with this particular topic. Now, surgical procedures that enhance fertility. Now, I said it is basically to enhance the spontaneous pregnancy. It is to enhance the IVF outcomes and fertility preserving surgery versus fertility enhancing surgery. Both are used very loosely, but there is a lot of difference between these two. Now, great explorers always started the unknown territories and bring the change that we are today. We surgeons are basically explorers, as we said, exploratory surgery, as we call it, to bring out the best. But it's very important as a surgeon, know when to stop and convert. I think sometimes keeping a step back is also equally good, than taking a step forward always, because ultimately the ultimate goal is bringing good to the patient, right? Now, I said we are all a team effort. In my team, it's a different thing. Together, everyone achieves more. I'm not here to say that endoscopic surgeons are best and the ERT specialists are the worst. No, we are here to have both of us together and working towards this common goal. Now, let me tell you, what we have to understand is there are a lot of correctable causes that we have. If you see that sometimes the embryo is at fault, sometimes the endometrium is at fault, and sometimes there may be a mismatch between the receptivity between the endometrium and the embryo. I, as an endoscopic surgeon, I have no role to play in this. My role comes down in the morphological causes of infertility. That is starting from the vagina to the peritoneum. Let's move ahead and see how we can go about it. Now, this is a very, very, now, 1 second. This is a very, very important slide. Now, if you see here, now, in all cases of IVF, if you did not do an hysteroscopy prior to an IVF, the chance of finding a problem is almost less than about 10%. You see that only 1 out of every 10 patients. We had a lot of debate with IVF hysteroscopy and whether to do a pre-IVF hysteroscopy or not. In every patient who is not conceiving and we go for an IVF and we do without a hysteroscopy, we may find it only about 10% of these patients. But then when you see that patients who have had a failed IVF, and then we go ahead and do a hysteroscopy for these patients, I think what is wonderful is we can see about 25% of these patients do have a positive finding. Basically, if you've had a case who has had a previous IVF failure, definitely go ahead and see for that, and you would find some amount of polypyrradations in these patients, and these are all correctable causes. And they're very, very simple procedures, correctable causes, but look at the pregnancy rate. It's about 25%. It's a very good one, which you can get. Now, coming to the hysteroscopy per se, I think it's time we give away the normal hysteroscopy where we do with the valcellum and the speculum. I think no-touch technique is the, I think it's a very small demonstration of the no-touch technique that I would like to show here, right? You allow the vagina to distance, you keep patience, you just put in the pressure and you can see the external laws, with the krebs and with the very small mucus welcoming you, right? So that's it, we go inside, be very careful, be very gentle, allow the pressure and the pressure will show your way out, right? You can see the crypts over here. It is very important you start from the cervical. You have to see the cervix, whether it is a healthy cervix, whether it's a scarred cervix. If you find a scarred cervix or an unhealthy cervix, how do you expect the sperm to move around into the uterus, into the tubes, and then have a pregnancy? It's very important you start from the vagina and see out everything. Again, same thing in the vagina. When you're doing a vaginoscopic method, see for the scars, see for the endometrium. The endometritis, signs of endometritis, whether there are vaginal infections. If you find all these things, the patient is not going to conceive at all, right? So you have entered in the cavity, wait for the distension, and as I keep saying, patience. Now I'm somebody with a very less number of patients, but then I have a lot of patience. Go ahead, allow the pressure to help you out, and you can see how wonderfully you can see the star-shaped ostia over there, the left ostia and the right ostia, and then onto the other side, turn the cord to the other side, and you can see the ostia. I think it's a very good technique. I think all of us need to work out on this, the no-touch technique. Mind you, not every case is easy to do a hysteroscopy with a no-touch technique, but as far as possible, do with the 2.9 mm scope, and you will be able to do that, right? Thank you. Now, next, as I said about the cervical causes, you can have the scarring, inflammation, the infection, narrowing, and the obstruction. Except for the last two, scarring, inflammation, infection, you have to see and treat. And if that is the case, then these are the patients which may actually be benefited from your IUIs. Okay, not merely just a simple one, but an IUI would be better. Right. Now I think I had a video of an I'll come back to that later on. Now coming down from the cervix, we start from the vagina, we have reached the cervix and now go to the uterus. We have the congenital causes, we have the benign, and we have the acquired ones. Now let's put the congenital causes over here. You can see over here. Now, again, I'm going and doing a hysteroscopy. You can see that you can see the ostia on the left side. Again, I turn my cord onto the opposite side, right? And you can see I just can't see any ostia on that. So basically, it's a unicornate uterus. So when you see a unicornate uterus, you can go ahead, you can see that. You can see over here, it's a unicornate uterus over here, right? And then very small rudimentary horn over here. Again, on the other side, you can see here, it's a uterine tidal phase over here, right? Not much can be done in these cases, but at least we have to know. You have to know the anatomy and anatomical problems, and later on you can go ahead. Unicornate uterus and the chance of having pregnancy with unicornate uterus is not very bad, or not very as much as we think about. They have very good rates, right? Now coming to the congenital malformation, I said I've shown the unicornate one, the bicornate, and the tidal phase. Also have the septate uterus and the arcate uterus. Now septate uterus is something which I really like, because it's a very, very simple procedure, and secondly, your chance of having a pregnancy is very good. Now, when you have a septate uterus, you can always diagnose it with an MRI, with an ultrasound. Now, with a very good ultrasound, as Dr. Sujit had also showed, you can really pick it up. Right? Now, here you can use a scissor, you can use monopolar. Okay, we use a Coulin's knife, it's a monopolar current over here. You can also use it a bipolar. You can see, and you can see the procedure. So the trick is always see medial. You can see the ostia there. Go ahead, open up the cord, see the distance between the ostia and this. And mind you, most of the perforations that we do are basically in the sides and not in the center. Right? You can see over here, again, go to the other side. Always, visualization is very, very important. Have a lot of patience, allow the fluid outflow to be open, clear all the cavity, take out all the blood, and then you see this. Right? Now, once you see this, that's how you go ahead. You can see over here, yes. use of a Collins knife here. Always start in the center. As I'm trying to do, come back, see. Keep the screen always in the center of the screen. Always keep it in the center. Make sure you're seeing whatever you're doing, right? Again, over here, septum is basically an avascular structure, right? So go very slowly over here, okay? White belongs, I always say this, white belongs to you, pink belongs to the patient, right? Whether you're doing a laparoscopic hysterectomy or any surgery for that matter. One which is white, where it is in laparoscopy, it's a coagulated one. Here you can see this is the avascular one. Okay, you can see here slowly, very, very slowly. Right. You can see here with the pressure also. There's such a beautiful pressure that we maintain. It just opens up on itself. Right. Now, when you reach the center, be very careful. No heroics here, no heroism over here. Be very, very gentle. Okay. You can see over place. See the ostia. Look for the ostia whenever you're doing. Look for the ostia. See how far are you away from the ostia. It's very important to know where exactly you have reached. That's when your perforation start occurs. Okay. Right. See over here. Sometimes when you see a very small subseptum, this is something which I've learned from my experience. You see a very small subseptum, don't be in a hurry to cut it. Small septums less than 0.5 centimeters or 5 millimeters is basically normal. You can see here, now when I decrease the pressure, if you've seen the previous one, when I decrease the pressure, you can see some small amount of bleeding which comes down. Okay. Basically, it's another trick to know whether you're right in the right plane or whether you're in the wrong plane, right? Or whether you need to stop. Where exactly to stop? Now, as we would all know, the moment you come back, you see both the osteas in the same visual field. It's when you stop the surgery, right? That's it. You can see the pressure also. The effect of the pressure is very well now explained over here. Right. Okay. There I see the ostia. There I see the ostia, and then I stop. Now, the same procedure again can be done using a scissors also. Now, the advantage of using a scissors is you can see over, I have seen the ostia, I have seen the septum. You can see there's a very small subseptum, but it's actually more than 1 centimeter, about more than 5 centimeters. That's why I'm cutting. Scissors, very good. No use of any energy source. Very easy to see. Not a lot of pressure. And the biggest advantage of using a scissor is you really have to work hard, to perforate. Unlike a Collins knife where you can easily perforate, with the scissors you have to be very, very, very hard to perforate. So the chance of having a perforation is very less when you use a scissors. Right. Now, again, the next one is the benign condition of the uterine cavity, the submucous fibroids and the polyps. And these two have got very, very good success rates in this. You can see here, there are multiple polyposis over here, which gets seen over here. Now, you can see here. Now, the thing that we normally do or normally should do is, you can see here what I'm doing. I'm opening the jaw and I'm trying to pull. Never do that always. What you have to do when you do a polyp, when you remove a polyp is go hold the polyp, push, and then you take it out. Right? If you pull it, get welsed and you can have a lot of bleeding. Whereas on the other side, when you can see over here, what's happening is you go hold it and you push and then you take it out. There's no avulsion, there is no bleeding. So the trick to remove a polyp is basically to hold it, push, and then you take it out. Now, after having shown this, the polyp, it's a very good study, which is a meta-analysis, which said, the management of endometrial polyps in subfertile women. Now, what is really good is you have a significantly improved pregnancy rates in women undergoing IUI with these patients, right? So that's the advantage of doing a polypectomy. It's a very simple procedure, but a very rewarding one also. Now, coming out to the fibroids, you can see the submucous fibroids over here. Here on the left side, what I'm using is the monopolar, where you have to use the glycine. You have to be very careful when you do this because you have to know the amount of fluid loss and everything. Now, see a very simple procedure and the glycine that's being used over here. On the right side, what you're seeing again is a similar procedure, but why I've put both these is you can see the difference between doing with a monopolar and a bipolar. On the left side, what I'm using is a monopolar one, and on the right side, what I'm using is a bipolar one. The advantage of using a bipolar one is the energy deficit is where the energy is easier to be used, but the problem is always hazy, and you have a lot of bubbles which come down when you use a bipolar. With a monopolar, the number of bubbles that comes, you can see here on the right side. Can you see, appreciate that? The number of bubbles that comes down is quite high. Of course, always rule out the air bubble before you start and do not cause any problem, or else you'll have to call Dr. Ajay Mane for your help, right? Say somebody, Ajay Mane is somebody who always, is at your doorsteps, who is always helping you with it. I think we find very few people who would always go ahead and help you when you're problem, in times of problem. When you're doing good, everybody is there with you. When you do wrong, when you have some problem, there's nobody. And that's why Dr. Ajay Mane is really helpful to all of us. Now, the hysteroscopic removal of polyps versus diagnostic biopsy. You can see here, it's all when you see the forest curve, you can see when you do a polypectomy, the odds ratio is on the positive side, which means that when you do this, the pregnancy rates are very high in these cases, and it's very good. And also, which means said by the statistically significant as far as the Cochrane has also used. Hysteroscopy for treating sub-40 doesn't major anomalies we have seen. It's a good one. Secondly, again, you can see over here, the same one with myomectomy also. Clinical pregnancy rate you can see is very high. It's almost about 5 times when you do a myomectomy. The odds ratio is about 5 times, which is really good. Now, the other advantage of an hysteroscopy, or when you do an hysteroscopy, is all the correctable causes can be easily treated. It's a good one. But of course, we have no role if the embryo is at fault. We have no role if the endometrium is at fault, and if there's a mismatch in the endometrial receptivity. But again, as I said, the morphological changes are always which are useful to this. Right now, coming to the acquired problems which are related to the uterine cavity, you can have the endometritis, synechia, endometrium, and adenomyosis. I repeat, I've actually used the word acquired causes in the cavity. You can also have an adenomyosis also. Right? If time permits, I will show you the videos of that. Endometritis is something which you commonly see in both, post-surgery, post-infective ones. We normally see a lot of cases over here. The video is not loading over here. We'll come back to that. Now, again, as I said, the same thing here in terms of operative hysteroscopy versus control in women undergoing minimal assisted reproduction with anomalies. You can see the odds ratio is also on the positive side in these cases. Now, these are all Cochrane reviews. We also, what about Cochrane reviews? We don't have any national reviews. We don't have any Indian data. That's why this is from a particular setup at Surat. We all know Dr. Nath Karni. We lost Dr. Purnima Nath Karni a few months back. This is from Adam's Place. And you can see here, when you have a polyp and you can see the percentage of conception. With a normal also, it's about 80.6%. Now, the reason for a normal hysteroscopy also sometimes you may be able to find somewhat. Basically, what you're doing is you are actually going into the cavity and you're doing something called as a coring also. So something like a coring also, which actually helps you. It also helps you to take care of your easier one to do an embryo transfer also. You know about the problems that are associated with the cavity also. If you see a polyp also, you see the success rate of polyp with about 55 to 58%. It's a very good rate. When you remove a septa with a septal resection, the pregnancy rate about 68%. Ostia, when it's blocked, I'll come down to that later, it's about 72%. Synechia is 71%. I'm not very sure about the synechia part of it because, basically it's synechia. If it's an Asherman's grade 1, it's okay. 2 and 3, I'm not very convinced about it. Now, peritubal adhesions is very, very important. Now, I've left my hysteroscope. I've taken off my laparoscopy now. You can see here, when you have no laparoscopic study, but then again, this is supposed to be. Now, this is very, very important. You can see over here, this is a peritubal adhesion. This is not basically an hydrostatic per se. This is basically the peritubal adhesion. So you can do a lot of laparoscopy. You can do a lot of dissection over this. Sometimes with these dissections, sometimes it is a pressure symptom that you see, and of course, yes. Now, this is actually because of the endometriosis that is a block over here. And again, you can see over here the same condition. When you start doing this, when you start doing the dissection, and that's it. And when the pressure is taken out, these which seem to be in hydrosalpingeal are actually helped out later on. So basically, you do an adhesive lysis, and that actually helps quite a lot for these cases. Okay, with simple suction and a counter-traction method. If for paucity of time, I would not go into the details of these surgeries. Again, as I said, proximal tubal occlusion. If at all I get a patient with with a tubal occlusion, whether it is a proximal, mid, or a distal, I would always pray to God that this patient should have a proximal tubal occlusion because it's the best one. It's a very easily corrected one. But there's one condition which you need to know, which will not be helpful. So, madam, give me about 10 more minutes. Madam was taking the watch. That is why just give me about 10 minutes. Right?
It's okay, sir.
The other aspect again is, as I said, salpingitis ischemica nodosa. So you have an SIN. Now, this is a case which is not a good condition for doing a hysteroscopic proximal cannulation. Now, this is what you use a guide wire. And you have to understand that the ostia is not basically a round shape. It's actually a J-shaped one. So we have changed actually the way the cannulation set has been, the design of the cannulation set is, with this. Now, again, you can see here, it's a proximal tubal occlusion. What we did again. Now you can see the cannula here. You see the guide wire. First you put the cannula, then you go for the guide wire. You can, whatever is comfortable with it. Basically, when you use when we're earlier using the guide wire first, now there will be a lot of extravasation which you have seen. Most of you would have seen that when you do with this, there's a lot of extravasation and that causes problem with it. So summarizing this, you have a proximal tubal occlusion, correct it, that's the best thing, the patient will have a pregnancy. Endometrioma is another big topic. I wouldn't go into the depth of it, but all that I would like to say is you have a smaller one, a stage 1 or a stage 2, you see a small endometrioma here at the uterosacral, regulated, do a diagnostic hysterolaparoscopy, do a tubal test, and these patients have a very good pregnancy rates also. And when it comes down to this, something like this, a kissing ovary, of course, it's a very difficult one, but again, paucity of time would just go. You do a cystectomy, you do the adhesive lysis, you do the cystectomy. But the most important aspect in cystectomy, what I would always suggest to you is go very slow, traction and counter-traction method. You can use vasopressin and this. Now, as long as you're in the right plane, it doesn't bleed. Now, all this looks very nice because in an edited video, don't mind, mind you, I also had a lot of bleeding in this, so don't worry. It happens with everybody. Now, very, very important in endometriosis is what I would take a different call from many of the seniors is, I always believe, do your cystectomy part very good, aggressive also. It's always better to leave behind a small disease-free ovary than leaving behind a big ovary with some disease in there. I think we are doing more harm to the patient. Of course, I do believe, the patient is more important. Of course, ART specialists will definitely disagree with me. I believe that the patient is what most important. The patient should be fine. The child will come later on. That's it. Right now, not all cases of endometriomas need surgery. I'm not here to advocate that. Now, patients who are unresponsive to medical therapy, patients would definitely require surgery to remove this. Now, what has been seen is 40 to 50% of these patients will spontaneously conceive, as all the seniors would have seen in cases of, simple cases, right? Now, very, very important before you blame the endoscopic surgeons for your bad IVF rates in cases of endometriosis. This is a very beautiful slide. Oocytes retrieved between operated versus non-operated normal ovary. You can see here, this is all the studies, all very big names. We have Jug Donors, we have Lowe, we have Somliana, we have actually Dr. Nargand also, who is basically in UK, but basically from North Karnataka. You can see here, in oocytes which are retrieved between an operated endometriotic ovary versus non-operated normal ovary, even in patients with an non-operated ovary also, the amount of oocytes which are retrieved are almost the same. Okay? Not only the oocytes retrieved, but let's go into the quality of them. Again, you see endometriosis and no endometriosis. You can see the amount of the oocytes retrieved are almost the same in each cases. Of course, reoperative stage 3 and 4 endometriosis is something which I always say. If you in a case which has been operated once or twice, do not use your surgical skills for these patients. Give these patients directly to the ART specialist. There's a very small role for endoscopic surgeons in such cases, and you see the difference. You give these IVF counterparts or friends, they'll be more than happy. They'll be doing a better job than what we would be doing. Of course, the indication for a repeat surgery is only one: a rapid increase in size and pain. Otherwise, for a repeat endometrioma, as much as possible not to go into that. Leiomyoma in infertility, I wouldn't go much into that. Just a few one. Submucosal fibroid, there's no doubt about that. The pregnancy rate of hysteroscopic resection is about 45%, which is a very, very good pregnancy rate. It was studied by 3 different studies from 2005, 99, and 2010. Intramural fibroids, I would just summarize in one line. If they distort the uterine cavity, you have a role to play in that. If not, do not do for the sake of pregnancy. I wouldn't go into that. Thank God I would just keep on for paucity of time. Again, I said repetitive outcomes. Now, impacts of fibroids on IVF, as I said, generally, if there is a distortion of the uterine cavity, remove the fibroids. There is no doubt about that. Now, because of lack of consistent or well-designed studies and high pregnancy reported rate, prophylactic myomectomy pre-IVF, if the cavity is normal, should be individualized and not routine. In simpler terms, you have a fibroid, and just because you have a fibroid, do not operate. If you have removed out all the other causes and you feel that the fibroid could be a reason for your failure of pregnancy, yes, there is a small role to play in that. But again, if the size is more than 4 centimeters. Now, unfortunately, we don't have any data for 5 to 7 centimeters, so we'll keep it aside. Right. Now, last a few lines about this. Okay. This is about the hydrosalpinx. You have an hydrosalpinx in such cases, right? You have a hydrosalpinx, always go ahead, remove. Now, be very careful and use the energy source because you do not want to decrease the blood supply to the ovary and then cause, because your ART friends are always waiting to catch up on you. Be very gentle, go very close to the tubes and take care of that. In cases when you're not able to remove the hydrosalpinx tubes, it is always better that you go down and just do the clipping part of it. Sometimes in a previous myomectomy, a previous colostomy, it's very difficult sometimes. Just go ahead and put. Now again over here on the left side, can anybody give me an idea about what exactly is this? Can anybody? No, not on the right side, on the left side. Right. This is called as an Allen Masters window. It's a very rare thing which is called as the peritoneal cause of infertility, right? Where actually you have a pseudocyst, you know, you can see, okay, we have a pseudocyst over here, where the peritoneum just covers the ovary, gives you a pseudocyst formation, and then all the ovum is being deposited there, and unfortunately there is no pregnancy in that case. So what you normally do is you separate it out, and you just cut it out, you separate it out, and then you put all these cystic, and that's how, you know, you can see over here, corpusculum also over here. So this is called as the Allen Masters window, though very rare. You know, it's just a good case that I just thought I will share with you. Right. Hydrosulfing, there's no doubt, sulfingectomy is definitely better. Okay, and that is the statement for choice. If you cannot do that, at least clip it, no issues. PCO, always the dictum. Once a PCO, always a PCO. I wouldn't go into the depth of the rule of 4, blah, blah, blah. All of us know that. Okay, we know about this. And with all due respects, which is good. But only thing understand is rule of 4 has been slightly changed now. Now the amount of energy that you use is called as a corrected dose that we give, and not exactly the 4 pounds. Okay, based on that. Now special occasions where you can see here. Now I'm sure all of us know the diagnosis. It looks like a fibroid. It is a fibroid for more often than not. See over it. We give vasopressin. Everything good, looks good. Okay. Ajay sir, if he's Ajay sir, is there any idea about what is this?
Yes, Subhash Bhau, I am listening and seeing your videos, ultimate videos.
हे काय माहिती काय?
काय बाबा, आता तुम्ही फार मधले तज्ञ आहात. काय सांगा?
Right. This looks like a fibroid. Okay.
Yeah, obviously
like
fibroid.
Yeah. I'm going inside. Now this is a video which does not belong to me. It belongs to Dr. Nitin Shah, right? Actually, so basically, this was a case of adenomyoma.
Chocolate cyst.
Yes, this is adenomyoma. Now you will have to rule it out from something called as accessory cavitator uterine malformation over this case, because there is no uterine line, there is no endometrial lining in this. If it were to be a case of accessory cavitator uterine malformation, there would be a uterine that would be a lining in this. Here, there is no lining in this. Basically, this is an adenomyoma with a definite. Okay.
Yes, yes.
Sorry.
Great video.
Okay. Now, again, I always believe in the dictum, since we have teachers of teachers here, Dr. Prasanna Kumari Madam also. You always, you know, when you teach somebody, you actually learn. That is a dictum which I have learned from Dr. Shailesh Puntabekar. When you teach somebody, you always need to learn. Now, knowing is not enough, we must apply. Willing is not enough, we must do. As Bruce Lee said, knowing and saying all these is not important. Applying whatever has been told in the webinar to the best of the nation's use is something which I really would like. Again, this is something which I really, I like. I am not disturbing anybody here. Is yes. One satisfied patient is worth thousands of guidelines and protocols. I think that's very, very important. At the end of the day, the patient should be happy, we should be happy, and that's what I should always believe. Right? Thank you very much, ladies and gentlemen. Thank you very much for that. And thank you very much for your patience also. Over to
Thank you, Subhash.
Beautiful.
Thank you, Subhash. That was wonderful. And I really appreciate you so many things about hysteroscopic surgery and laparoscopic surgery. About hysteroscopy, I really appreciate you saying that you have to give up the valsalum and the speculum for hysteroscopy. Because if you use a valsalum and dilate the cervix and put the hysteroscope, she may go, even if she conceives, she can go in for abortions. She can go in for mid-trimester abortions. And another thing about hysteroscopy, it's not been done unnecessarily. And diagnostic hysteroscopy should be largely replaced by ultrasound. And if the ultrasound shows in some abnormality, then only you need to go for hysteroscopy. And if this patient is found to have a septate uterus, she doesn't conceive, or if she goes for repeated abortion, then only she can be taken up for septum resection. And this coring of endometrium that is being done by so many people. I'm not referring to Subhash. That's being done by so many people before IVF. That causes a lot of adherent placenta, especially in the upper segment. And we have to, sometimes we may not be able to do a segmental resection because the placenta will be adherent in a large area. If you resect most of the endometrium will be lost. So that also should not be.
That's a very good point, ma'am. That's a very good point, ma'am. Even I actually learned it now. Yes, very true, ma'am. Very true.
Encounter that. That's it. Being in an IVF center, we usually encounter that increta and all those that hysteroscopic coring of endometrium prior to IVF procedure. And about laparoscopy, you put endometriosis, you put the laparoscope, you confirm the diagnosis, you find a stage 3 or stage 4 endometriosis. Don't try to release the addition or it won't be fruitful and you will be destroying her endometrium. Sometimes there will be a endometriosis patient who had a laparoscopic endometriotic cyst resection, and then she comes to another infertility specialist and she thinks I can do a better job. She will again do a laparoscopic cyst removal and reduce her AMH level to less than 0.1. So we should not be going for a repeat laparoscopic procedure for endometriosis. We can straight away take the patient for IVF. So first do no harm, that should be the principle. The hysteroscopic, the laparoscopic endometriosis, adenomyosis. I also had a patient who had a large cystic lesion in the endometrium, and that was chocolate cyst in the myometrium, large endometriotic cyst in the myometrium. So that also is rare and rarely seen. And sometimes we find large, multiple small endometriotic cysts enlarged with an enlarged uterus up to some 20 week size. So that type of adenomyosis also is seen, and it's better not to go for surgery. And if the IVF fails, it is magnetic resonance ultrasound. That should be the treatment of choice. So I really appreciate you, Dr. Subhash. You have touched very important points and your videos were wonderful. Thank you, Subhash.
Thank you, ma'am. Thank you very much, ma'am.
What about the chat box? No questions in the chat box? No questions in the chat box.
We are actually running late by half an hour, ma'am. That's right.
It's all cleared by Subhash. So nobody has doubts.
I just wanted to give one compliment to Subhash that he is a second Puntambekar, Dr. Puntambekar. He is Dr. Second.
Second Puntambekar. Okay.
No, sir. No, sir. There is only one Puntambekar, sir.
No, Subhash. You are a great surgeon. I have seen your videos. Great.
Beautiful.
Thank you, sir.
Beautiful.
Thank you very much, sir. Thank you, sir.
Thank you,
The
sir.
collections are so good, no? You have presented each and every type of cases which we come across. So the collections are superb.
Thank you, ma'am. Thank you.
Yes, ma'am, with wonderful videos. Thank you, ma'am. Now we are moving to our next session. That is on panel discussion. The topic is hyperglycemia in pregnancy, and to moderate this panel, we have two expert moderators, Dr. Suman Sinha Madam, who is the President of OBGY Society, Ranchi. The next moderator is Dr. Sangeeta Menon Madam. Ma'am is the Additional Professor, Department of OBGYN in Government Medical College, Trivandrum. And she has a career spanning 23 years in medical college, has been filled with academics and teaching. Driving passion is working with reduction in cesarean section rates and maternal mortality. She is the assessor for the confidential inquiry into maternal deaths and captain for maternal near miss surveillance and response and the trainer in ORRT. And ma'am is currently the secretary of the Trivandrum OBGY Society and active member of the medical education unit. Now I hand over this platform to Dr. Suman Sinha Madam to kindly introduce our panelist.
Okay, thank you, Archana. And now, after the very comprehensive and elaborate deliberations by your esteemed, eloquent speakers, we move on to the very exciting, much awaited webinar on hyperglycemia in pregnancy, which we all know needs much attention because of the rising incidence of GDM in our country. Preventing GDM prevents diabetes mellitus for the 3 generations. And I like this slogan, Ek Jaanch Bache Do Jaan. So for this, I have gathered a galaxy of star-studded faculties who are highly accomplished and very knowledgeable and very experienced. First of all, I welcome Dr. Sangeeta Menon, Madam, the co-moderator of the panel, and then I welcome all the experts. And I'm going to read out the CVs. Dr. Geeta is Senior Consultant at the Mother Hospital, Thrissur, Kerala. She has been former professor and unit chief, Amla Institute of Medical Sciences, Thrissur. She is presently President, Thrissur Obstetric and Gynec Society, and her interest is in high-risk pregnancy. So this topic is according to her interest. So can I have the next CV? Our next expert is Dr. Simi Kurian. She is Associate Professor in the Department of Gynae in the Government Medical College, Kunur, that is Periyaram. She is presently Secretary of Kunur Gynec Society, and she has graduated from the very famous Government Medical College of the Thrissur. She has done a post-graduation from Government Medical College, Kochikode, and presented various papers in state and national conferences. Regarding the next, can I have the next CV? And this is the CV of Dr. Meenu Priya. She is a consultant gynecologist and laparoscopic surgeon in the Bishop Benazir Hospital, Kollam, and also in the Lifeline Infertility Clinic, Kollam. Presently, she is Secretary of Kollam OBG Society. Welcome, Dr. Meenu. Next. She is Dr. Deepa Madhavan. Presently, she is in Dubai, and from there she has connected with us. She is Junior Consultant, Government District Hospital, Kanhagad, Kerala, and she is Secretary, Kasargod OBG Society. Next. She is Dr. Deepthi PS. She is presently Assistant Professor in ONG TG Medical College, Alappuzha, and she has graduated in DGO in 2009 and MS in OBG in 2010 from Sath Government Medical College at Trivandrum. And she has 2 research articles published in international journals in 2020 and 2021. Next, please. And this is our Dr. Reena Godsara. She is our treasurer of Ranchi OB-GYN Society. She has been trained in ultrasound at Chikitsa Ultrasound at Mumbai. She has done a fellowship in gynae endoscopy at Akola Endoscopic Center, Maharashtra. She has diploma in ART technique at 21st Century Hospital at Surat. She has also been trained in advanced laparoscopic in CMAS Center of Excellence for Minimal Access Surgery training, Mumbai. Next, please. And now she is Archana, we all know, and she has already been introduced. So I move on to the panel. The first part will be taken by me, that is on GDM, and the next part will be on the overt diabetes, that will be taken by Dr. Sangeeta Menon. So I will be sharing my slides. Can you see my slides?
Yes, ma'am.
Yes. Yes, ma'am.
Is it visible to you all?
Yes, yes.
Yes, ma'am.
Yes, ma'am.
Okay, just a minute, give me a minute. So the topic of today's panel is hyperglycemia in pregnancy. Why we have chosen this topic? Because we all know that 6.2 million live births are affected by hyperglycemia in pregnancy, of which 5.9 million are due to GDM. GDM, as per FOGSI guideline 2021, is defined as carbohydrate intolerance resulting in hyperglycemia of variable severity with onset or first recognition during pregnancy. GDM is defined in this way includes women with undiagnosed pre-existing diabetes as well as women with first onset hyperglycemia during pregnancy. In the past, Less severe GDM was referred to as impaired glucose intolerance and more severe as GDM. But now the whole higher end of the glucose spectrum is more simply referred to as GDM. FIGO recommends the term hyperglycemia in pregnancy, whether the diabetes is before pregnancy or during pregnancy or because of the pregnancy. We also know that pregnancy is a form of stress that can cause latent diabetes to manifest. In most of these cases, the carbohydrate intolerance will revert back by the end of the puerperium, but this manifestation may be the first indication of diabetes yet to come. So the incidence we have already discussed. In India, the incidence is very high. It is 14%, more high in the urban than the rural population. So my first question goes to Dr. Simi. The question is why the pregnancy is known as a diabetogenic state.
Thank you, ma'am. First of all, let me thank the organizers, especially Dr. Suman, for giving this opportunity. And as ma'am said, the pregnancy by itself is potentially diabetogenic. This is mainly because of insulin resistance, which is produced because of the hormones produced from the placenta, like the human placental lactogen, cortisol, estrogen, progesterone, which are all insulin antagonists. And second thing, there is increased destruction of insulin by the kidney and the liver. And thirdly, there is increased lipolysis, which is happening during pregnancy, again leading to hyperglycemic state. And fourth point is there is change in gluconeogenesis. That is, because of the insulin resistance, the insulin is not able to suppress the gluconeogenesis. As a result, the blood glucose level increases.
Yes, thank you, Dr. Simi. So we can say that during pregnancy, when the patient has normal tolerance, normal glucose tolerance, then these placental lactogen, estrogen, progesterone, they are insulin antagonists, So they and insulin and the insulin antagonists, they remain in balance, whereas patients having poor glucose tolerance, they will increase the insulin resistance and the insulin will become less sensitive to the tissues, and that is the reason of increasing blood sugar and the result of GDM. So we start with the first case, and the case goes to Dr. Reena Godsara. This patient is a 34-year-old lady. Her married life is of 4 years, and she is now in her first pregnancy. And this pregnancy is very precious because she has conceived through IVF, and she has come to you for the first antenatal checkup at 10 weeks. Her family history reveals that mother has type 2 diabetes mellitus. So, Reena, what are the risk factors for GDM? And does screening do screening required in this case?
Yes. First of all, I want to say good evening to everybody. Thank you, Suman ma'am and Kiran ma'am, Ranchi Option Gynae Society and the Kerala Society who has given me this opportunity to be a part of this mixed bag webinar for this. Yes, for this patient, like for this case, the risk factor for these are like the patient is elderly, high maternal age, is high parity, high BMI, and high pregnancy weight gain, and PCOS. And if the family history is of diabetes, and if the history is of maternal GDM and high intake of saturated fat, these are the risk factor for GDM. Alpha thalassemia trial, like if the patient is having a previous history of stillbirth, congenital malformations, macrosomia, GDM, previous cesarean section for the macrosomia, and the pregnancy factors like if the patient is having high BP, multiple pregnancy. And thank you.
So would you like to screen your patients?
Yes, ma'am. In like we are in the Indian ethnic population, so there is a very high much risk of this developing GDM. So I'll go for the screening, and for like the universal screening, I will go for.
Okay. Okay. Yeah. So now is Deepa over there?
Yes, ma'am.
Okay. Thank you, Dr. Deepa. So is screening required in your patient? As Dr. Arina has already said that yes, it's doing the screening, but which type of screening you will offer to your patient? Will it be universal or it will be selective?
Okay. A very good evening to all of you. And thank you, Suman ma'am, for the opportunity. Definitely screening is required and I would go for universal screening. As already said, the Indian population is considered to be at risk and universal screening has to be offered. At the first visit, we have to advise the OGTT with 75 gram glucose. And in the first trimester, if it is negative, we have to repeat the screening test around 24 to 28 weeks of gestation, where it's the period where the insulin resistance is high.
So what is this selective screening, universal screening? You have already said.
So selective screening is offered to selective screening. We don't screen every people, only offered to patients with high risk cases.
Yes.
Offer the screening who has body mass index greater than obese patients, who has a strong family history of diabetes,
Yes.
then previous history of IUD, stillbirth, all those cases we offer.
Yes, in the countries where the prevalence is less, they select the high risk cases and they do this test. But in our country, it is not possible because by doing that, we miss 30% of cases. So we prefer doing universal screening in all the patients. So what are the risk groups, Archana Pathak?
Thank you, Suman ma'am, for giving me this opportunity. Like every antenatal woman should be screened for GDM, and this is divided into two groups, like high risk cases and low risk cases. So ideally the high risk cases are whose age is more than 35 years of age, or those who are having a strong family history, those who have previous history of GDM, or unexplained stillbirth is there, if there is neonatal death, or if there is macrosomia, the baby weight is more than 4 kg of weight, and if the person is having bad obstetric history. Then there are low risk group also, in which the age is less than 25 years of age, there is normal BMI, no family history, and no history of GDM, and impaired, there is no impaired glucose tolerance. Then these all groups belong to the low risk group.
Okay. Dr. Deepti, at what period of gestation tests should be done? At 16 weeks, 12 weeks, 8 weeks? When should it be done?
Ideally, the Indian belongs to the ethnic group with high prevalence, and so according to the Indian guidelines, you should start screening at the first antenatal visit itself, because by 24 to 28 weeks, ideally the international standards uses the selective screening, but unwise to delay the testing beyond 20 weeks because late detection can reflect a loss in the opportunity for control. So it's ideal to screen at the first visit itself.
Thank you. Thank you. So we have already dealt with what is selective screening and what is universal screening. Okay. So Dr. Geeta madam, please define one step and two steps test. What is that?
Yeah, one step means the patient has to come only once, which will be maybe an advantage for the definitely will be an advantage for our Indian population, because it may be difficult for us to call back the patient and then do. Whereas the previously we used to recommend the two-step test. That is, first we are going to do a screening test, like a glucose challenge test, that is a 50 gram glucose is given to the patient, and then if the blood sugar is more than 140, some say 130, okay, and then if that is positive, then we go for a full OGTT after patient preparation. So that will include a fasting 1 hour, 2 hour, and 3 hour. So whereas what we are following now is according to the DIPSI guideline, which probably is more acceptable to the Indian population. So, and
also cost effective, madam.
Definitely, definitely. And it is more acceptable because they don't have to come fasting. They don't have to come again for testing. So the GTT, that was the previously recommended one after the O'Sullivan and Mahan GCT. This is the Carpenter-Couston and the what is the ACOG recommendation. That is the fasting more than 95, 1 hour 180, 2 hour 155, and 3 hours 140. So if one value is abnormal, then they consider it as only impaired GTT. But if more than one value, or if the fasting is abnormal even, then you have to consider that as a GDM and start treatment.
Yes, ma'am. Thank you so much. What are the criteria for GDM apart from that?
That is for me again?
Yes, madam.
Yeah. Actually, the problem with diabetes in pregnancy is that the main thing is that there is no consensus among the different areas of the world as to what is the, when do you call it GDM? Though we know that diabetes is a very prevalent thing and that we should control it, there is nothing like a common consensus among, if you take the UK criteria, you take the US criteria, and you take the Indian criteria, everything is a little bit under WHO. Everything is a little bit different. So we are following, I think because we have quite a lot of diabetic patients coming to our clinic. So we are following the DIPSI. But these are necessary for somebody else who wants to know the criteria. So according to the NDDG group, the cutoffs are 105, 190, 165, and 145. And according to ADA, it is 95, 180, 155, which is almost similar to the Carpenter-Kushner. Only thing is the third R value is not there. And WHO says you can take the cutoff is 126 fasting and 140 at 2 hours. So if two or more criteria are, that is 2 or more values are abnormal, then you have to consider them as GDM. So you want me to tell about DIPSI test or somebody else is going to tell?
No, somebody else, madam.
Yeah,
Thank you very much for your suggestions. So, Dr. Simi, again, the question goes to you. Can you explain the DIPSI procedure?
According to the DIPSI, it is a one-step test, as already Geeta madam has explained. Whenever the patient comes, irrespective of the previous meal, whether she is fasting or not, we will give her 75-gram oral glucose load. And after 2 hours, the venous blood sample will be taken. And the GDM, if the 2-hour plasma blood glucose level is more than 140, you make the diagnosis as gestational diabetes. So the advantage is that the multiple visit to the hospital can be avoided and the multiple withdrawal of the sample can also be avoided. And it has been validated by Padma Shri Dr. Sheshaya, and it has been published in 2009. So what we instruct the patient is that she need not be empty stomach. She by herself can do it at home. She should mix the entire content of the 75-gram glucose in 300 ml of water and should drink it within 5 minutes. And the next 2 hours, she should not eat or drink anything. But if she is feeling thirsty, she can have the plain water. After 2 hours, blood sample is given. And if the blood sugar level is more than 140, she should consult the doctor. If vomiting occurs within 30 minutes of intake, the test has to be repeated later.
Good. Thank you very much. So benefits you have already explained. Fasting not required. It has a good compliance and serves as a screening as well as a diagnostic tool. So can you interpret the DIPSI test? How do you interpret this?
Okay, so after the 2 hours, if the plasma glucose level is less than 120, you take it as normal. If it is between 120 to 139, you take it as a gestational glucose intolerance. If it is more than 140, you make the diagnosis as gestational diabetes. But if it is more than 200, that means you can take it as a patient with overt diabetes.
Yes, thank you, Dr. Simi.
Ma'am, may I add one more point?
Yes,
to
yes,
that?
madam.
Because we already said that we should do it at the first visit and at 24 to 20, if that is normal, at 24 to 28 weeks. From our experience, we have also added on that even that is also recommended that we should repeat it in the 3rd trimester, because quite a few of the patients do develop GDM in the 3rd trimester also. Especially what we have found is patients who sometimes complain of decreased fetal movements or those who are, by ultrasound, if we find the macrosomia polyhydramnios, then those are the patients who may develop GDM in the third trimester. But even without that, I think we should make it a point.
Yes, and all the trimesters it will be better. First trimester,
Yeah, it
second,
should be
and
done.
third. Yes, even I agree to it. Thank you.
Thank you.
So what are the other tests which can be used for screening apart from that? Suppose patients, you have done the DIPSI test and you have found that the test is positive. Would you like to do something else?
Yes, ma'am. We would like to do glycosylated hemoglobin, glycosylated fructosamine, and glycosylated alamine, and fasting blood sugar.
Yeah. But what you are doing, because these things are not done. Only.
Yeah. I usually go for the glycosylated hemoglobin.
Yes. Why, Dr. Dina?
Glycosylated hemoglobin because it reflects the mean glucose level of previous 2 to 3 months. So we'll get an idea about the percentage of anomalies scan. It's a value usually it ranges from 5.3 to 6%, and accordingly, like the level is like up to 6.5%. There is no increase in the chances of the congenital malformation. If the value is 7 to 8.5%, it's about 5% chances of anomalies. And here it is not written, ma'am, but if the value is 8 to up to 9%, there is a chances of 10 to 25% of congenital malformation. And if it is more than 10, it's more than 22% chances of anomalies, anomaly in the baby.
Up till 8.5, it is about 5%, but more than that, it is 20 to 25%. It's 22% only have written, but it's up till 25%. Thank you, Reena.
Thank you.
So these tests we are not doing. So Dr. Meenu, what are the complications of GDM?
Good evening, ma'am, and thank you for the opportunity, Suman ma'am. My question is GDM, what are the complications of GDM? So basically you can classify the GDM complications to maternal complications and the neonatal complications. So the maternal complications, basically it includes birth trauma. That is because of the macrosomia, there can be a lot of perineal lacerations and such issues. So that is one thing. And second thing, there is an increased rate of cesarean deliveries due to macrosomia itself. And the third point that that can complicate a GDM case is preeclampsia, because you often see hypertension or preeclampsia in association with GDM owing to the insulin resistance or due to the increased obesity incidence in GDM cases. The fourth point is polyhydramnios. And due to the polyhydramnios or macrosomia, patient can end up in a preterm delivery. And in early pregnancy, you can have a spontaneous abortion also. And there is a postpartum effect of diabetes. They can have an impaired glucose tolerance or diabetes later in life. There is almost a 80% chance of patient developing a lifetime risk of diabetes in a patient of a GDM patient. So that is regarding the maternal morbidity. Then you coming on to the fetal morbidity. Again, birth traumas due to macrosomia, shoulder dystocia, cervical fractures, Erb's palsy are all common in GDM babies. And there is a high rate of perinatal morbidity because of respiratory distress syndrome and other electrolyte imbalances that can happen in a neonate in a GDM mother. There can be hypomagnesemia, hypocalcemia, hypoglycemia, and also polycythemia. And they are also at risk for obesity in later life, and it is a a definite implication of impaired glucose tolerance in the baby herself or itself.
Sure. So, how does hyperinsulinemia affects the baby? Because hyperinsulinemia, we all know, no? It has this insulin-like growth factor. So it can cause
hyperinsulinemia basically causes insulin resistance, and basically that is the major reason of organomegaly. So what happens is it causes organomegaly, there is an expansion of the abdominal circumference in such babies, and also there is a decreased surfactant that is also in relation to insulinemia, and they can have they can go into respiratory distress syndrome. Again, birth trauma owing to the increased adipose accumulation over the shoulders, the babies can go in for birth trauma. Again, neonatal hypoglycemia is a very common complication that we see in our NICUs of the GDM mothers, the babies of GDM mothers going into hypoglycemia. Again, intrapartum asphyxia and increased erythropoietin. All this can be due to the hyperinsulinemia in the baby.
Yes, thank you. And also you can have the skeletal things, no? Like
Congenital malformations is altogether a different thing, ma'am. Skeletal malformation.
So this is another case, the last case which I'll be taking. A 29-year-old lady weighing 70 kg. She's 29-year-old and her weight is 70 kg. She is gravida 4, para 1 with history of 2 abortions. Presented with single live fetus of 27 weeks. On her ANC evaluation, her glucose tolerance was found to be deranged. Fasting was very high, 106, 1 hour 184 and 2 hour 168. Dr. Deepti, what history is important in this case and how to follow up her during routine ANC care, and what investigation you like to do? Dr. Deepti, are you there?
Yes, ma'am. Yes, ma'am. So
please tell us.
Important I would like to know is about her 2 abortions, her previous pregnancy.
Yes.
When was her previous 2 abortions occurred? And she has only 1 live child previously. So I would like to ask whether her glucose levels were checked in the previous pregnancies. Now she is 70 kilogram overweight, and so next I would like to, since her fasting sugars is also normal and 2 hour value is also abnormal.
Abnormal, yes.
Abnormal. So I will advise her on diet control and ask her for HbA1c to know whether her previous 3 months value was normal or not. Then also I would like to do the HP, blood urea and creatinine level, whether she is over diabetic or not, because she has 2 abortions in the past and now she came at 27 weeks. So I would also like to do a thyroid
profile, yes.
Thyroid profile and urine protein creatinine ratio, and I will ask her for diet control. Initially I will ask for medical nutritional therapy, and then I will do a fetal, since she is 27 weeks, from 28 weeks have to start on growth scans. So 28 weeks I will do a growth scan, and thereafter 4 weekly growth scans has to be advised for her. And no need for fetal Doppler if there is associated fetal growth restriction or associated gestational hypertension. Then I will ask her for a daily self-monitoring of blood glucose levels.
Teacher, no? She has to do herself.
Ideally 7 times fasting, and pre-meal and 3 post-meal values have to be checked.
Yes, initially 4 to 7 times, and then we can tell her to do 3 times.
Every 3 days, okay.
So I think with this, do you like to do fetal echo in every case of diabetes GDM? Fetal echo?
No, ma'am. If it is over diabetes only, we need to do the fetal echo, because it is occurring at the organogenesis period. The gestational diabetes usually develops after 24 to 28 weeks. So if early over diabetic only, then we will ask her to advise for the prenatal screening and all fetal echo and all.
And rest of the antenatal management will be like other normal pregnancy. Yes. So this fundoscopy, ECG, echo, you have already said that the cases in over diabetes. But it's better to do a fundoscopy in your patient just to rule out any changes, because this is likely to have, yes. So how do you, I mean, if she is in after 28 weeks of pregnancy, would you like to do the BPP?
Part of fetal surveillance has to be begin after 28 weeks.
Yes.
Ideally, fetal movement counting every 28 day from 28 week onwards, and NST also after 28 week, 32 weeks onwards, and ultrasound and biophysical profile weekly have to be done. That's all. If the anything is abnormal, you have to start on ask for biophysical profile testing also.
Yes, this is very important. Patients should be told about the fetal movement because sometimes patient may become hypoglycemic and the fetal movement may get reduced. And if they don't know where to go, whom to consult, then maybe we can lose the fetus. So better to tell her after 28 weeks when she comes from checkup, you must tell her that she should keep and watch on her baby's movement. And so how it is, if she has 10 movements in 60 minutes, then it's okay.
Yes.
Yeah, she should feel assured. So what are the indications of termination of pregnancy?
So the indications for termination are severe diabetic nephropathy is there, proliferated, active proliferative diabetic retinopathy is there, or HbA, the termination if the HbA1c level more than 10%.
Actually, these all occurs in over diabetes. This doesn't occur in GDM, because I think Dr. Sangeeta will be taking the over diabetes, and all these things will be discussed. So with this, thank you all the panelists for your experience sharing. So I stop here and invite Dr. Sangeeta to share her slides.
Can I share my screen?
Yes.
Yes, ma'am.
Is the screen visible?
Yes.
Yes, sir.
Yes, ma'am.
Yeah.
It's kind of late in the night, and I won't keep you all long. Just another 6-7 slides to go through something about hyperglycemia and the overt diabetes part of it. There's just one thing I'd like to mention from the previous discussions. The biophysical profile has a lot of fallacies in gestational diabetes because anyway the LICA is going to be high. So AFI is not going to be relevant in biophysical profile. And if the sugars are uncontrolled, there is going to be sugar in the LICA as well, and the baby will move more than what it actually should. And it will also exhibit a little bit more gross body movements. So biophysical profile per se in a diabetic is really not of much use. But what is important is sugar control. Everything is based on control. And you can't actually predict the intrauterine fetal death at all, whether it is in the over diabetes or in the gestational diabetes, because it all depends on control. If she's well controlled, there is no polyhydramnios, there is no macrosomia, she's likely to fare well. I think the biggest impetus should be on stick to your diet, stick to your insulins, monitor your blood glucose at home. And most of them, if you can write out a chart for them and tell them what is normal, I think they may fare well. I'll just go on to what in a minute or two, we'll just get along with our job. A 34-year-old second gravida comes for her booking visit at 7 weeks. She is obese. Her BMI is 41. She's had GDM in her previous pregnancy. That required insulin as well. And for some reason, some gynecologist has done an RBS, which is a little worrying for all of us. And it says 210. So I'm worried. See, in hypertension, we know that it is after 20 weeks. In diabetes, there is nothing, there is no cutoff. It says hypoglycemia, either first appearance or diagnosis in this pregnancy. So, Geeta, madam, we'll start with you. Would you say she's an overt diabetic?
Definitely, Sangeeta, because her RBS is 210, which means she's already in a state of hyperglycemia. According to the WHO criteria also, if you anything more than 200 you are getting, then that means she is a diabetic. So,
but will you send a HbA1c as well?
Yeah, in this particular patient, I think an HbA1c is going to help because that will help you to have an idea of the her glycemic control over the previous 3 months. Unlike a GDM where the HbA1c may not be as useful, here I think it has a role, and to counsel her and for us to have an idea about her diabetic control over the previous 3 months.
And as Madam had very clearly said, the HbA1c in gestational diabetes is really not of much use, because even at, let's say, 32 weeks, if you find that her control was poor, you really can't do anything about it unless refer to your HAPO, which is hyperglycemia and adverse pregnancy outcome, and tell the woman that, look here, your sugars have not been under good control, you may face an adverse outcome. Other than that, you really can't do anything. So she is an over-diabetic. And this 28-year-old comes to you for preconceptional care. She has been a diabetic since the age of 18. When she had irregular cycles, diagnosed with PCOS, she was obese, and she was diagnosed with diabetes at that stage. She's on insulin and she's married now, and she would like to know if she can conceive. Minu, what would you tell her? Can she conceive? What kind of preconceptional care will you give this woman? It's very rare that we get them for preconceptional counseling, but let's say we do get them, what would you do?
Madam, the question to me, ma'am, my internet was a little unstable for some time, so I didn't hear it. Okay, ma'am, because this patient is a 28-year-old and she is already a diabetic for the past 10 years, and she is already a diagnosed case of polycystic ovarian syndrome. So there is already hyperinsulinemia and there is hyperglycemia. So what in this case, what I would like to do is, I would like to tell her that you have to check your HbA1c levels, and you have to see whether your HbA1c level is less than 5. Only then you should try to conceive. Can you hear me?
Yeah, we can.
Ma'am, can you hear me?
Yes, we can, Minu. Go ahead.
Ma'am?
Yes, we can. You can turn off your video of the...
Ma'am, can you hear me now?
Yes,
I think I have a little problem with my internet connection. It's getting a little...
You turned off your video, Dr. Minu.
Okay, I think I can turn off my video. Okay. So the second point, what I would like to do is, I will tell her the need of a good glycemic control. That is, her HbA1c levels should be less than 6.5 ideally. I would tell her there will be a higher risk of miscarriage or higher risk of congenital malformations, higher risk of stillbirth and neonatal death in case her HbA1c is uncontrolled. So we should also tell her about our normal target glucose that we need her to achieve during this pregnancy. Second thing I would like to tell her is, I would like to give her preconceptional folic acid because she is already at high risk for congenital malformations. Then all her other medications should be reviewed because she's already a diabetic. We should actually check whether she's already on drugs for any hypertension or such drugs. So in case she's on any AC inhibitors or any kind of beta blocker, we should actually it should be reviewed prior to her conception. And the fourth point is, she's already a diabetic woman, so we should rule other causes of other problems such as vasculopathy. Like we should rule out a retinopathy or a nephropathy. So we should check her renal function test and also refer to her to an ophthalmologist to do a fundus examination. So this is basically, and also ask her to do a healthy diet. The diet part, the glucose self SMBG part, we should let her know, and we should preconceptionally itself we should start all that, so that her HbA1c levels are controlled.
Yeah, and also look at her kidneys to see.
Yes, imaging of her kidneys.
Yeah. And see, she's now 28, so she's been a diabetic for 10 years. So if you look at the Priscilla White's classification of diabetes, she is just crossing from A to B. That means she's got more than 10 years of diabetes. She will not unlikely to have vasculopathy, but you can never say. So yes, her eyes need to be looked at, her heart needs to be looked at, and her kidneys need to be looked at. So this white is really important because once you find that her kidneys are either she has hypertension or she's pouring proteins in her urine with microalbuminuria, or she has a proliferative or a background retinopathy, things change in pregnancy. They become more complicated. There are more stillbirths. They have preterm births. They have IUDs. And even the nephropathy and the retinopathy can become worse. So if she has a proliferative retinopathy, it's better to have it laser coagulated prior to pregnancy rather than tackle it during pregnancy. So that's the importance of really getting her for preconceptional care. So she comes to you in a year's time and says, you know, I'm pregnant now. But as dictums rule in most parts of India, they won't come in the first trimester because they don't want to, they feel coming to the hospital may not be very auspicious. So she comes at 10 weeks and she's been taking the same injection Mixtard 30/70. She's been taking it at 20 in the morning and 18 at night. But when you look at her sugars, her fasting is 140 and her postprandial is 210. Dr. Archana Pathak, would you like to, what is your experience? Would you like to continue with her Mixtard or would you change it?
Ma'am, I would like to go with the Mixtard because regular insulin causes immediate control of the sugar. It may cause the risk of hypoglycemia.
Yeah.
Yeah, and ma'am, we may start the metformin also.
Okay.
In this patient.
Okay, fine. You can start metformin. Does
Yes,
anybody have any experience with any other oral hypoglycemic in pregnancy like glyburide, or does anybody give it?
Ma'am, we can give the Dinagliptin also, Dinagliptin M.
Pardon?
Ma'am, we can give the Dinagliptin M also.
Okay.
Huh.
But glyburide really is not, though it is recommended in pregnancy,
yeah.
2.5 milligrams, the control appears to be quite good, but whereas metformin has a large trial as well. There's a MIG tofu trial that tells you that women who've had metformin, the babies fare quite well. The little arm circumference is a little bit more than the other babies and at 5 years, but they do very well. So you can continue her, but suppose you find that her sugars are not under control. Deepti, what is your thing? Would you, either she's not under control or she suddenly develops fever. You know, she has a very high fever. I'm uncomfortable with the Mixtard, which has an intermediate acting. She has very high fever. Let's say she has COVID. Would you like to give her regular or still stick to the Mixtard?
I would like to change to multiple doses of short-acting insulin. Yeah. And since our fasting is high, I will add intermediate-acting insulin at night. Yeah. So I will give a control over the fasting sugars also.
Okay. And so that's what you could do. And most importantly is for them to understand that they can inject themselves any part of the body. Actually, if you look at the Western literature, they'll see even over the abdomen to give it into the subcutaneous fat is fine. So once they're told that, they're quite happy, and they're taught, many of them are taught in the OP how to take their subcutaneous insulin, and they do well. The only thing is you need to ask them whether they have a fridge at home, because it has to be refrigerated, not the pens. So we did something about termination, but Dr. Reena Gotsara, what about, we said 10 is the cutoff for HbA1c, and you're talking about anomaly rate of 20%. Do you actually see those rates, or do you see much lesser rates? Do you actually allow them to continue? What do you do?
No, ma'am. If it is a 9, I would not go for termination.
Yeah. Okay.
I'll go for the.
Okay. Let me up the gears a bit. Let's say it's 10.
Suppose it is 10, I'll go for termination, and along with that, I look for the anomalies and all that other things, madam, whether the blood sugar of mother is controlled or not. I mean, not only on the basis of the HbA1c, I will go for the termination. We have to look for the fetal and maternal conditions both.
Okay. So basically, it's a it's an informed kind of a decision, because even at 10 grams, some of them decide at 10 HbA1c, some of them decide to continue their pregnancies. They have a little bit of problems with control, but with our level 3 ultrasounds, at least the big anomalies can be detected, as well as the cardiac. Actually, more than the sacral agenesis and the sacrococcygeal teratomas, what we usually see are cardiac defects, and that can be detected. So if she's well informed and she wants to continue, it can, but she must be told that there is an incidence of increased incidence of anomalies. So
yes, I think Sangeeta, we should not decide on a termination based on the HbA1c level alone. Because even if it is 25% abnormality, still a 75% is going to be normal.
Yes.
And many of these anomalies we can pick up with a detailed scan, I think. Yeah. So I think.
And Geeta madam, do you actually see these 25%?
No. Yeah. Because presently I have a patient who has come to me with 9.7 HbA1c, but I think we'll take it from there. Yeah.
Absolutely. I'm so glad.
Ma'am, can I say something?
Sure, Archana.
Ma'am, in this, the right of termination should be given to the patient.
Absolutely.
Yes, definitely. Yeah.
Yes, ma'am. And the this should be explained to the patient, and consent should also be taken.
Yes. Definitely.
Definitely. But at the same time, the way you present it to them also matters. If you tell them point blank that at 10 you have a increased incidence and it's 25%, 1 in 4 babies is likely to have it. You could also say 3 out of 4 will not have it. That's
Exactly. That depends on how you present.
You have to counsel also. Counseling is very important.
Absolutely. So does anyone see me? How do you actually, very often we find this hyperglycemia is a killer. So we need to bring those sugars down. And maybe only where these proliferative retinopathies are concerned, we don't want a drastic fall in sugars, but otherwise we really like their sugars to come down. So Simi, how do you decide? Let's say she has a fasting of 140 and a postprandial of 220. How do you really decide how much of insulin you're going to give her? Do you do a sliding scale? Do you go by weight of the patient? Do you go by trimester? What is it, Simi, that you usually do?
Once we admit the patient to the hospital, we start the insulin in a lower dose. And usually we start with either with the combination short acting plus intermediate acting, or we start with regular insulin in a small units, that means in a low dose, and then we do the 7-point sugar profile. And depending upon the 7-point sugar profile, we will increase the titrate the dose usually. And then if the blood sugar, if the fasting, if there is fasting hyperglycemia, if it is not getting controlled with the regular insulin, we may start the intermediate acting insulin at night. And then depending upon the sugar profile, we do the adjustment of the insulin dose.
Yeah, so it should not take too long to bring her sugars down. In the sense, what I mean is when you have a very high sugar, 4 units really will do nothing. It won't even tickle her pancreas at all. So
sliding scale is
larger doses may not be the sliding scale, but at least half of that you need to start. I'm not saying you need to increase very fast every day. Where you could wait for 2 days, but provided you started on a fairly good amount of insulin. Does anybody use the newer insulins?
Yes,
ma'am.
Geeta madam, do you use?
Yes, Sangeeta. We're both Sparta and Lispro anyway we are using. And we do use the Detamir also. Yeah, to get the basal.
Yeah. So what is your experience with the Detamir? It's a long-acting insulin.
Yeah, we have found that it brings down it helps to maintain the hyperglycemia in patients who are not, because that is expensive. We cannot use it for all the patients. But for patients who require a very high dose of insulin, or those who are not well controlled with your 3 times dosage, or with your the twice daily dosage, then probably it would be a good idea. It is a good idea to add. So in such patients, we are adding on the Detamir.
Yeah, Detamir. We have no experience because in our kind of setup, they can't afford this kind of thing. But yes, Detamir.
Madam, what about Lantus, ma'am? Glargine?
Glargine, no. Glargine, actually, they say you can use it. But if the patient is well controlled on Glargine before, probably there is no harm in continuing. But I have no experience on that. But Detamir, we are starting also. And those patients who are already on Detamir, we are continuing also.
Glargine initially was a no for pregnancy, but now it has been said that you could use it. They have started
category C, still.
But still, maybe a little bit more needs to be said about it. It's still category C. Deepa, what about your OHAs? You give metformin along with insulin, maybe only metformin. What has your experience been with metformin in pregnancy? Deepa? Yeah. What is your experience with giving metformin in pregnancy? Deepa?
Am I audible?
Yeah, you are. You are. Yeah, Deepa? What is
Deepa,
your
you are
experience with
muted.
metformin?
Yes.
Can you hear us?
Yes, yes, ma'am. Yes, ma'am.
What is your experience with using metformin in pregnancy? With
Uh,
even with diabetes, over diabetes?
If the patient is controlled with not controlled with the nutritional therapy, adding of metformin
Is good. Yeah. But do you think that they all go well, especially the over diabetes? Do they go till
no,
term?
but it's better, but we get a fair control with insulin therapy only.
Yeah, so in over diabetes, it's a little different from gestational diabetes. I think the stimulus to start insulin should be very strong. Especially in the first trimester, you have very high values. This diet and exercise may not work too much. So you have a very high value, it's better to start. Yes, exercise, diet, metformin also can be added, but I think in an overt diabetic, insulin really is very important. You can add in a lot of adjuvant therapies as well.
Because maintaining the sugars in the first trimester is extremely important. So starting a metformin at that point will not be useful. So you have to, with this particular patient, it will be 140 to 10. Definitely, she needs insulin.
Insulin, absolutely. So some of our women believe, or rather most of them believe, that they need to eat for 2 people while they're pregnant. Especially in Kerala, there are different kinds of banana that we have, a yellow kind of banana. They feel that that is the thing for the baby, but it also happens to cause a lot of hyperglycemia. So how is it that you really tell them, Deepti, how would you tell them about a diet plan? It's not like, it's difficult to say 40% this and 30% this. What do you really tell them? Deepti?
Madam.
Yeah.
I would advise them mainly this complex carbohydrates should be reduced. So that is whole grain, all that should be reduced. Complex carbohydrates should be more used because that will not cause increase in hyperglycemia, postprandial hyperglycemia, and should divide that into 3 major meals and 3 snacks, so that the immediate hyperglycemia is not happening there. And then I will advise then adequate protein intake should also be there, along with that fat intake, of which saturated fat should be less than 10% should be advised.
Okay. This 3 meals and 3 snacks, they're quite excited because it's 6. They think it's 6 meals a day, and you tell them that they have to have a wheat-based diet at night, and then maybe not in Ranchi, but definitely in Kerala, they're used to having a kanji, which is a porridge at night, and it's very difficult to get them away from it. So I think this in pregnancy, the morning push of insulin is slow. Even the circadian rhythm, if you look at insulin, the morning is very slow. So even if they don't split any meal, they must split their breakfast. Yes. So they have 3 idlis, they have 2 at 8 and 1 at 10 o'clock. So the splitting breakfast must be explained to them, and definitely little rice and lot of vegetables. And protein, you could tell them egg, fish, whatever, because basically the most of Kerala is non-vegetarian. And tell them that at night they have an early supper and have something very light. So they always say they are hungry. So when they are hungry, what do you tell them to have? Geeta madam, let's see what madam will. She'll have some nice fillers. What do you tell them to have?
No, actually, they do tell that. But so we ask them to have something with protein, or they can have like a salad. So they can make the salad more acceptable, because if you are just having like vegetables, cut vegetables, I don't think the Kerala people are going to accept all that much, which is a difficulty. So you can make it more interesting by adding sprouts or peanuts or something like that, which will make that they fill their tummy at the same time they don't increase their glycemia. So that, yeah.
So
And
non-vegetarian also, ma'am. You can add chicken or egg also.
Yeah, but
Egg
I'm
whites.
myself being a vegetarian, so probably that's why it came out like
So
that.
I'm always telling
Protein
them,
biscuits are there, na? Protein biscuits
yeah,
are there.
protein biscuits, but the very many of them can't really, they won't spend money on these kind of
Yes.
things.
That is the.
We tell them to have groundnuts, we tell them to have green gram dal, which is really, sprouted and had, and along with a lot of vegetables. I keep telling them, go eat whatever you find green, please have it. So
Yeah, adding a little bit of like the chart, like lime juice or something, which you can make the thing interesting. I think that will be more acceptable to the patient also.
Yes, ma'am.
So we've already gone through how often we'll monitor as a 6-point or a 7-point. So there's just another thing, Dr. Archana. She starts having a blood pressure of 140/90 by 32 weeks. And that is something that we expect not only in GDM, but also in OVERT because she has a vascular problem. At 140/90, do you start antihypertensives?
Yes, ma'am, we can start antihypertensive because like in further course, she may develop eclampsia. So better to start with the antihypertensive.
So, no, you could choose whatever is your antihypertensive that is available. Do you have alpha methyl dopa available in Ranchi?
No, no.
No, ma'am,
Don't
no,
have
it's not available.
Labetalol only.
Whatever is your antihypertensive, but remember that we're all 140/90 is our cutoff and is also something of our control, if you ask me. But if you look at the non-pregnant diabetic, they'd want their BPs to be maintained at 130/80. So that same thing applies to pregnancy and overt diabetes as well. If they are hypertensive or they start having hypertension in pregnancy, their blood pressure should be maintained at 130/80. So definitely 140/90 is indication to start the antihypertensive. So at 32 weeks, she develops a fever, she's breathless, she's tachycardic, she's dehydrated, she comes into the casualty. Her rapid antigen and RT-PCR are negative because that's what we think of with fever and breathlessness today. Her RBS is 402. We know she's an overt diabetic and she's still on the Mixtard. Now it's up to 30/20. So what are we thinking of and how does one proceed? Anyone? I guess Simi.
Okay, ma'am. So this patient definitely with the history of fever, breathlessness, and tachycardia, there is some source of infection in her body. And this infection might have precipitated diabetic ketoacidosis and the acidotic breathing, and she's breathless also. And her RBS is also 402. That means the blood sugar is also not controlled. So definitely this is a case of diabetic ketoacidosis. So we require the hydration should be maintained. That means dehydration should be corrected. The blood sugar should be strictly controlled. The acidosis should be corrected. And then we have to go for the control of infection. So, and we have to do the investigation. For confirming the diagnosis, we have to do the arterial ABG, then the urine for acetone, a complete blood count, serum electrolyte, the renal function test, and for the infective pathology, the blood culture and urine culture should also be done.
Yeah, so basically it is you push it. So very many of us will need medical help at this stage. So you call up your friends in medicine. But while they come, for us, it takes them a few hours to come. So I always say start hydrating her. Make sure your investigations are in order. Send off potassium bicarbonate, your ABG, everything, but hydrate. So you start off with about 10 to 15 ml per kg body weight. In the first hour, you push in that liter. Then you can come down. By the time your medicine help comes, you can come down. And if the sugars are this high, you need to start IV insulin. Roughly at about 0.5 to 1, so about per hour, you may need to give about 4 to 5 units of IV insulin and monitor the potassium and the IV insulin very closely. But remember, at the same time, think of the baby as well, because the 32-weeker can have fetal distress. You need to know the CTG, and ketosis is a huge problem for these babies. So you need to look at the baby as well. So Reena, how would you think about your over diabetes? Fairly, this kind of control. Sometimes diabetic ketoacidosis, sometimes hypoglycemia, but not much of macrosomia or polyhydramnios. The baby looks a little small. She's now 36 weeks. What is your take on delivery?
Do you terminate them? She's a primey. Do you terminate them by cesarean? Do you induce what? When do you induce these women?
Up to 37 week, I would like to expected management. I would like to go for up to 37 weeks.
Okay. Does anybody want to wait a little longer?
38.
38. Yeah.
No, ma'am, she has a very brittle diabetes. No, ma'am, she's going into diabetic ketoacidosis, and in between she has hypoglycemic. So if she has a very brittle kind of thing, I think it's better to terminate early.
Yeah, because the hyperglycemia and bad pregnancy outcome really tells you that at any stage when her sugars have been high, even up to 140, 150, they say bad outcomes. But also bringing these babies out earlier, if she has IUGR, yes, 37 weeks. But with no IUGR, maybe 38. But that call is a very dicey call. When do I really terminate? But you monitor them very well and opt for a vaginal delivery. There's no cesarean section for these. And monitor their sugars. Really, how does the baby, what kind of criteria are you thinking of, Deepthi, in labor to bring the baby out nice and healthy? Deepthi? I think she's not there. Okay, I guess it's really late. This is the last one. Cindy, how would you like, what kind of, if you have a baby that's born, how do you want to make sure that it doesn't have hypoglycemia and problems at birth?
Means, ma'am, after delivery, you're saying?
No, during labor.
During labor, okay. So during labor, we should monitor the blood glucose level of the mother. And then hourly, we do the blood sugar testing. And there is a sliding scale. And depending upon the sliding scale, we will start the insulin infusion in dextrosaline. And depending upon the blood sugar level, we adjust the dose of the insulin. And the urine acetone also will be sent. The electrolytes will also be checked. Regarding the monitoring of the baby, we monitor using the continuous electronic fetal monitoring.
So basically the last few hours of birth, if her sugar has been at 120, the baby is going to come out without large amounts of cord C-peptide, and the baby will not have hypoglycemia at birth. But if you've had really high sugars during your intrapartum period, baby is going to fare poorly at birth. I think that's my last one. Thank you very much. Oh, is that, yeah, I guess that's
already.
it. Yeah, that's it. Contraception, absolutely. Contraception, does anybody want to take these?
Yes, yes, Sangeeta, I would like to.
Yeah.
No, actually, I would, long-term follow-up of these women after delivery is also very important because actually that should come in GDM rather than in the overt diabetes, because overt diabetes anyway, we are going to have them come to us for, or to the physician for follow-up. But in GDM, I think we should check their sugars at 6 weeks. Then they advise them every 6 months or at least 1 year because they are at risk of developing cardiovascular complications, future diabetes, and hypertension also. So that has to be done. And even the infants should be of diabetic mothers should also be followed up for possible complications in later years, and advised on lifestyle modifications so that we can control the NCDs in the long term. And contraception, we can use because an effective contraception is a must. So though they can use barrier contraception for the first few months, which will be okay. But most of the methods of contraception, except the probably the hormonal, combined hormonal, can be used freely. And combined with, if there is nephropathy, vasculopathy, then probably in such patients, we should be careful when we are using combined hormonal contraception, or even this intrauterine devices also. If she has a bad case of vasculopathy, then you have to be careful. Other than that, I think we can use most of the implants.
DMPA injection is also kind of alters the carbohydrate metabolism.
I know, but that should be used with caution. That's all. If it's sugars are okay, then probably yes.
The WHO medical eligibility criteria.
It will be 2. Yeah, it will be 2 for combined hormonal contraception and DMPA. And I think for IUD, it's usually even the hormone releasing IUD also, you can it can be used.
Blood sugar
But-
is well controlled. We can
Yeah.
give anything. If not
Anything.
controlled,
And
yes.
even if the blood sugar is controlled, you can even put a postpartum insertion of IUCD.
Yes, IUCD.
And I think Geeta madam brought that out. This should be considered, having a gestational diabetic should be considered as the best public health opportunity for you to screen them for later onset, advise them some kind of lifestyle modification. Because what WHO predicts is that 1 in 3 people are going to be diabetic by 2050. I'm not really sure whether we'll all be there at that time, but I'm sure the younger generation is going to be there. So 2050, every third person positive, you jolly well start looking at your gestational diabetics very seriously. Thank you very much. I think it was
One more question I have, ma'am.
Yeah,
In
sure.
this first trimester, ma'am, because mostly people will be vomiting and they'll have all that nausea, vomiting. We may not be able to do the DIPSI or the OGTT in the first trimester. Can we just do with HbA1c and FBS? Is that enough?
HbA1c is a recommended fasting, is a recommended screening method. It may not be very applicable to the masses because of its cost, but you could even do just a simple fasting and a post-breakfast value. Post-breakfast. We always say post-breakfast because the morning push of insulin is slow in pregnancy. So if you're going to pick it up in pregnancy, you look at a post-breakfast value, 2 hours.
Thank you, ma'am.
I think TIPSI recommends in the after 12 weeks, right?
Yeah.
I think so. Yeah. Early, though we say it's early, so probably by that time nausea, vomiting, if that's reduced, then that's the time, and we can have the first TIPSI.
Thank you very much. I don't know whether you guys enjoyed it. I enjoyed it.
Yeah, really enjoyed Sangeeta.
Thank you so much,
madam. Thank you.
Thank you so much.
As well.
Thank you, ma'am.
And Archana as well, and all my friends from Kerala. Thank you very much.
Thank
you, ma'am. Thank you, Sangeeta, ma'am.
Thank you so much, ma'am. That was really a power-packed panel discussion, I would say. And now I request our Secretary Rocks, Dr. Kiran Trivedi, ma'am, to kindly give the vote of thanks.
Thank you, Archana. So this panel discussion was mesmerizing. So a lot of discussion, interactive session it was. So good evening to one and all present here. On behalf of Ranchi Obstetric and Gynecological Society, I want to thank all the dignitaries who have graced the occasion. Firstly, I want to thank Dr. Madhuri Patel, ma'am, Secretary General FOGSI, who had given blessings for our webinar in form of inspiring words. It was a privilege to having encouraging words from her and the guest of honor like Dr. Ashwath, Dr. Pardesi sir, and Dr. Maya Verma ma'am, who is our teacher. It is great opportunity to express my thanks to Dr. Sujit, Dr. Mane, and Dr. Subhas for their crisp, concise, and informative talk. I thank all the chairpersons, Dr. Rekha Jha, Dr. Prasanna, Dr. Pramila, Dr. Saiju, and Dr. Jyoti for their contribution and valuable time. I also want to thank moderator, our Sumandi, and Dr. Sangeeta ma'am for and all the panelists like Dr. Geeta, Dr. Simi, Dr. Meenu, Dr. Archana, Dr. Reena, Dr. Rani, Dr. Deepa, and Dr. Dipti for their interactive discussion and enlightening us for our day-to-day practice. I also want to thank Dr. Archana for conducting the session so nicely. I also want to extend my thanks to Shield Pharma Company for their support and effort to make this webinar a success. My special thanks goes to Dr. Suman Sinha, who is president of our society and always there as pillar of strength for us. And all the delegates, they are the main, they are here to make any academic session the successful one. Lastly, I want to thank and give the best wishes to Suman Sinha and Dr. Ajay Mane sir for their candidature in FOGSI. We wish all the best and we hope that you will come in as a leader in front of us and will carry forward this our representation in FOXI. Thank you, Sumandi. Thank you, Ajay Mane sir. And thank you all the delegates and dignitaries. Thank you all. Good night.
Thank you, Kiran, and my heartfelt thanks to all the STEAM faculties who are present here. And on my one call was there, and everybody said yes. So it was such a, I mean, good blessing to me that nobody refused my call, and everybody was present. And wherever I approached, I got a good response. So I'm really very, I mean, I'm not getting worse.
It was a tiring day for me. Hectic day, OT day was there in medical college, but still the talks were so nice that I was here since evening. Till I reached home.
Very fresh, apart from your hectic day to day.
Yes, thank you, Suman madam, and
thank you,
Kiran
Dr.
ji.
Subhas.
Thank you, Archana ji.
Thank you, madam. Thank you very
Sir,
much.
आपको बहुत-बहुत शुभकामना.
Thank you, ji.
आपको
Thank you
बहुत-बहुत
very
शुभकामना.
much. Sir. And thank you, Dr. Stalin from Shield Connect.
Thank you so much, sir.
Today's is Ms. Suman from Shield, sir.
Yeah, Suman.
Yeah, Suman. Oh, I'm so sorry.
There are two Sumans.
Sumanji from. There are two Sumans.